a chance. There we go.
Hey, there we go. Again, good morning. Thursday, March 24th, 9 a.m. We are ready to start our meeting. The Advisory Committee for Resilient Nevada. I'd like to call this meeting to order and start taking roll call. Sheila?
Thank you. Jessica Barlow. Jessica did indicate she would be late today. Brittney Collins-Jefferson.
Present.
Lilnetra Grady. Ryan Gustafson is excused. Dr. Kamyar.
Present.
Karissa Loper.
Present.
Katherine Loudon. Show is absent. Cecilia Maria.
Present.
Elyse Monroy.
Present.
Darcy Patterson.
Present.
Colleen Sala. Show is absent. David Sanchez.
Present.
Ariana Saunders.
Present.
Cornelia Sheehan.
Present.
Laura Sherwood.
Present.
Dr. Wagner is excused as absent. Winnie Winbush.
Present.
We do have an 11 in attendance, Mr. Chair. We do have a quorum.
Thank you, Sheila. Now that we have quorum, we will move on to agenda item number 2, public comment number 1. Do we have anybody available or interested in making public comment?
John, I see in that Jamie Ross from the PAC Coalition would like to make a public comment.
Jamie, go ahead.
Good morning. Can you hear me?
Yes, we can.
Thank you. Hello, I'm Jamie Ross, Jamieross, Executive Director of the PACT Coalition. I sat in on many of the ACRN meetings and noticed that opioid prevention has not been extensively covered in previous meetings. My comment will focus on your Johns Hopkins guiding document, Principles of the Use of Funds from Opioid Litigation, Principle 3, Invest in Youth Prevention. PACT covers Clark County and currently receives funds for prevention programs in schools, after-school programs, and throughout the lifespan. Currently, PACT provides funding for CCSD to do a school-wide, year-long, evidence-based prevention program in elementary schools. We were able to increase this year to 4 elementary schools in Clark County of the 224 elementary schools. Evidence-based prevention programs such as life skills, positive action, and others have long-term proven effectiveness following the science of prevention principles. At the locations we fund, we see increased attendance, increased connections to school and community, and higher grades. The issue we face is scalability. We currently fund 26 programs in over 100 locations through diverse funding streams, but we could easily add so many more locations. We receive requests for additional prevention funding weekly, but our current funds have already been allocated. While Clark County certainly has the largest population, this issue of scalability could be stated in all counties. Currently, every county in Nevada is served by Substance Misuse Prevention Coalition, who would be able to scale up programming if additional funds were found. I'm hopeful that this group will focus on prevention in your process. Thank you.
Thank you, Jamie. We have a couple more people for public comment. After Jamie, I have Anne Elizabeth Norton.
Good morning. Can you hear me?
Yes, ma'am.
Perfect. I am Anne Elizabeth Norton, the Executive Director of Join Together Northern Nevada, serving Washoe County. I'm here to talk about the importance of prevention to our communities and to the discussions and decisions of this group. I'm passionate about making a difference in the lives of our community. I was born and raised in Washoe County, and I love this state. An important aspect of making a difference in the substance misuse field is to carefully consider the continuum of care, which of course begins with promotion and prevention. Trauma-informed services and trauma mitigation are at the heart of prevention efforts across the country, and there are many systems that support this effort. The CDC and Kaiser Permanente discovered that trauma increases risk for 7 out of 10 of the leading causes of death in the United States. The Adverse Childhood Experiences Study, questions of which are now included in the Nevada Youth Risk Behavior Survey, or YRBS, results in the ACE's special report for specific regions in Nevada, informs a large portion of our prevention efforts. I encourage all of you to review this data and to utilize it in your decision-making processes. Prevention coalitions make a broad impact on trauma mitigation in our communities. ACE's mitigation for our coalition looks like going into schools and talking about coping mechanisms through an evidence-based program, educating counselors in Washoe County School District about the effect of trauma and how to recognize it in our students, and parent programming that teaches parents to recognize their children's trauma, to engage in difficult conversations, and to help them find meaningful solutions. It looks like Handle with Care, which was put into law and brings all stakeholders to the table to handle our children with care, to mitigate their trauma, to show them the steps to a meaningful and resilient life. Pediatrician Nadine Burke-Harris encapsulates prevention perfectly. She says, one of the things they teach you in public health school is that if you are a doctor and you see 100 kids drinking from the same well and 98% develop diarrhea, you can go ahead and write that prescription for dose after dose after dose of antibiotics. Or you can ask the question, what in the world is in this well? Prevention coalitions in Nevada look into the well. On a daily basis, we ask ourselves, what is here and how do we impact the source? We know that one source is trauma because we have a structured, data-driven approach to prevention. In recovery, there's a common anecdote of a man stuck in a dark hole, and I'm paraphrasing here. Different people, counselors, lawyers, etc., come by and ask that person what they can do to get out of the hole. Finally, someone crawls into the hole with the man and says, I've been here before and we can get out together. Prevention doesn't always receive recognition for this role, but I know that when my staff makes a connection with a child, or JTNN provides training to counselors on ACEs strategies, or we have a conversation with a parent, that we are crawling into the hole and we are reaching for traumatized people at the very beginning of the continuum of care. I can say with certainty that trauma-informed services and ACEs mitigation are a hand out of the darkness. Prevention coalitions in Nevada and our many community partners engage in structured, meaningful, data-driven work that provides a hand out of the darkness and increases community capacity to be that hand for all walks of life. Thank you.
Thank you. The next person I have up for public comment would be Wendy Madsen. Healthy.
Good morning. Can you hear me?
Yes.
Wonderful. Wendy Madsen, Director of Healthy Communities Coalition, serving rural Northern Nevada and Lyon and Story counties. Excuse me. We are a substance use prevention coalition that serves as the backbone agency for collaborative efforts across the county. Part of the collaborative includes HCC's placement of school-based safe school professionals, which consist of teams of social workers from LCSW, MSW, BSW, and community health workers. This team works in tandem with school counselors, teachers, and administrators within the school district. As the advisory council continues the conversation of the needs for Nevada, I'd like to reinforce the great need of focus on our youth. Our kids are in crisis. This is not a statement I share lightly. Safe school professionals are reporting and sharing great concern for our youth, the mental health needs, high rates of students at risk of failing, suicidal ideation, attempts, self-harm. We are seeing our elementary level students in crisis like never before. Administrators who have been teaching for 20 plus years are sharing that they've never seen anything like it. Calls to mobile crisis, 911, and the increased need and request from our schools for counseling to respond to the needs of our 6-year-olds. Our kindergartners on up are in need of services. With that, the concern of widespread substance use among our youth in schools and parents' acceptance of use is common. It's been shared that some parents feel that vaping and other substance use may aid in their child's mental health in helping them cope with the transition of back to in-person learning and the disconnects and isolation during the pandemic. As for assessing the need, we need to respond collectively and act now. We need to recognize the importance of a spotlight on prevention. As we are seeing our kids engaged in risky behaviors at younger ages, we need to get ahead of these issues. A focus on healthy choices, strengthening of community activities, clubs, safe spaces, intergenerational opportunities within our senior centers, as they too are suffering, opportunities to bring our elders and our youth together, mentorship, community involvement, and increased supports in our schools where the kids are at. More school-based mental health providers, increased teams of safe school professionals. Alongside treatment, we must place great supports in school and community-based prevention. With barriers and access to care, collectively, let's ensure we have a laser focus on getting ahead of these issues in our communities through prevention and school and community-based opportunities to increase supports and protective factors for all. Thank you.
Thank you, Wendy. The next person I have for our public comment is Katie Zeller.
Good morning, everyone. Katie Zeller, project coordinator at the Churchill Community Coalition serving Churchill County. I'd like to talk a little bit about pain management. So the U.S. Department of Health and Human Services draft report on pain management best practices recommends that restorative therapies be utilized as an alternative to prescribing opioid medications. These approaches are evidence-based, and research shows that restorative therapies play a significant role in chronic pain management. They can be administered by a variety of different providers in different settings. Patient outcomes tend to emphasize overall improvement of well-being, and they hold value in helping maintain patients' functionality. Use of these therapies is often challenged by the lack of insurance coverage. Through the utilization of the Attorney General Volkswagen settlement funds, prevention coalitions throughout the state provided a variety of these practices free of cost to high-risk community members ranging from young children to senior citizens. All of these practices were taught by trained professionals. Offered therapies included, but were not limited to, an assortment of mindfulness, yoga, Reiki, Qigong, Tai Chi, meditation, and other forms of mind-body connection practices. More importantly, many of these were offered virtually during the height of the pandemic when many did not have access to healthcare. The goal was to find a way to offer these free classes and provide access to a well-rounded community-based approach to addressing alternative pain management. Unfortunately, these settlement funds have since ended, and subsequently more funding is needed. Thank you.
Thank you, Katie. I have Sophia Allison as the next person for public comment.
Good morning, everybody. My name is Sophia. I'm with Nye Communities Coalition. We are a prevention coalition that serves Nye County, Lincoln County, and Esmeralda County. And today I wanted to note the importance of prevention when it comes to discussing substance misuse. With all of the health issues, prevention is the most effective, efficient, and impactful intervention that can be made. We don't consider speaking of heart disease, diabetes, injuries, or suicide without significant consideration of the role that prevention plays, both while a child and developing our behaviors and throughout our life as we go about living. From the SAMHSA substance abuse cost benefit analysis, we learned that the cost of substance abuse is in the high billions for the United States. It is clearly among the most costly health problems in the US. If effective prevention programs were implemented nationwide, substance abuse initiation would decline for 1.5 million youth and be delayed for the 2 years on average. It has been well established that a delay in this onset reduces subsequent problems later in life. Research has shown us that for every $1 invested in prevention, it would save us about $18. Prevention is a return on investment like no other, and it is also cost effective. The average school-based program operates at $220. However, prevention is much more than that curriculum-based programming. As we look at where to invest our resources in the state, we need to consider the whole continuum of care related to substance misuse. In the current SAMHSA strategic plan, many of the identified activities fall within the continuum of care of prevention, either in the promotion, universal, selected, or indicated populations. The continuum of care to and between prevention and treatment is key to reducing the harms of alcohol, tobacco, opioids, drugs misuse. I would appreciate your consideration for how we can consciously incorporate prevention as a key tool in this plan that you are developing. Thank you so much for your time.
Thank you, Sophia. The last person I have for public comment is Laura Osland.
Thank you for allowing us to speak. I am Laura Osland with PACE Coalition, and I cover Elko, Eureka, and White Pine counties. So many of my cohorts have spoken very eloquently about what prevention is, and to go with what Sophia was speaking on, prevention is not just the boxed sets. We also need to think of the interventions and the continuum of prevention. We need the trainings, we need more mental health services, we need more mental health awareness trainings. Looking at the coalitions, we understand our service areas. There are 10 of us that cover the 17 counties, and we work closely with the agencies and organizations, the community members, local government. We have an understanding of the needs, where the prevention would best be placed, but we need to also be able to branch out into the intervention and to support the recovery with prevention programs so that the recidivism is cut down and that we are able to reach the families and the friends and all who are impacted. We work with law enforcement. We need to be able to support both law enforcement and those who may be incarcerated. So to be able to implement and increase the prevention and intervention that is necessary to have healthy communities would be greatly appreciated. Thank you.
Thank you, Laura. I believe that is all we have for public comment. I do have a message in chat, but I believe that is the close of public comment. Sheila, does that sound right to you? You're on mute, Sheila.
Joan, I'm going to refer to you. Do you see any other hands raised?
I don't see anybody else.
Yes, Mr. Chairman, that would be the last of those who have indicated they'd like to speak.
Thank you. We will move on to agenda item number 3 at this point. We have an introduction of Joan Waldock for professional and administrative support and Don Yohey as the new clinical program planner 3 for the director's office opioid program.
Thank you, Mr. Chair. As you know, we have been short-staffed, and I'm very excited today to share that Joan Waldock has joined our team. She will be providing administrative and professional support. And also we have Don Yohey, who is going to be the clinical program planner 3, who will be managing the opioid litigation project and the clinical support. And kind of want to just give Joan and Don an opportunity to give a quick introduction of themselves. Joan, would you like to put your camera on and introduce yourself? You're on mute.
Hi, I'm Joan. Let me know when there are problems with meeting invitations or anything like that, and I will provide any other support that this group needs. You all have my contact information. Thank you.
Hi, everybody. I'm Don Yohey. I was a clinical program planner over at the Bureau of Behavioral Health, Wellness, and Prevention, overseeing the mental health block grant funds. So I'm really excited to transfer in this role. A little bit about me. I am an MFT and an LCADC. I do have history working with MAC clients. as well as youth and adolescents. So excited to be part of this team.
And that's the end of our introductions, Mr. Chair.
Thank you. Thank you for introducing yourself, and thank you for being a part of this. We are going to move to...
So, Chair, I have a question for staff.
Sure.
Thank you. This is Elyse Monroy. I have a question about I guess how staff from the opioid program will support the committee. In the past, I've asked for a couple administrative things to be done to help promote transparency to the public on the committee. Specifically, we asked for the recordings of these meetings to be placed on the website with the minutes. Since we can't do a verbatim minutes. And then we also asked for either, I asked for either introductions of committee members to be placed on the agenda, or for staff to collect bios. I think this is our 4th or 5th meeting and neither of those things have been done. So now that we've got some additional staff support, if those things could be done, I think it would be helpful. I know that everybody's names, titles, and organizations are included on the website, but that doesn't really give you a lot of background of what people do and the perspectives they bring to the committee. And then I'll just kind of, why that's important is we didn't even get to introduce ourselves before we picked a chair. So we actually really don't know each other. We also can't reach out to talk to each other, which makes us working collaboratively as a group a challenge. So if those bios can be collected and posted, or if the next agenda can include an agenda item to introduce ourselves to the public, that would be really helpful.
Mr. Chair, response, actually, Ms. Monroe, we do have your request for the bios. They are in work. We're doing those off of the resumes for those who submitted for the committee. This, without the administrative support, this has been delayed. So it is on the list to be completed. We are actually working to streamline these meetings where they actually go straight to the YouTube and that they will be captured on the YouTube channel. Unfortunately, after working on this Friday, we had a couple of additional technical challenges to ensure that that could work fluidly. We do provide the actual update of the minutes that are recorded, and there have been some limitations with Electron and changing of services, but every meeting recorded will be available, and we are working through those technical changes, and we're also working through the new structure. So I just want to ensure that none of that fell on any deaf ears. We recognize the importance of it. It's just the capacity was not there. And so now we have both administrative professional capacity. We have Ms. Yohey joining us. We also have permission to hire 2 additional positions within the same opioid unit. So I would anticipate that this particular committee will see a much more robust level of engagement and a much more timely response with the additional support.
Thank you for your question, Elyse, and thank you for your clarification, Sheila. Just wanted to note, as we move from introduction to the next agenda item, that we have a member of the public, K-Tree Saunders, has been posting in our chat. Thank you for being here and sharing with us. We will now move to agenda item number 4, which is the discussion and possible action to approve the minutes for the January 13th, 2022 meeting. Does anybody have any issues with the minutes that were posted? Can we move to approve those minutes? Do I make the motion, Sheila, or does someone else?
Sorry, this is Elyse. I'll move to approve the minutes.
I'll second.
Thank you both. Sounds like there are no issues. We have a motion to approve and a second. The minutes from our last meeting have been approved.
You have to call for, sorry, this is Henna Rasul, Senior Deputy Attorney General. You need to call for a vote.
Thank you. Can we take a vote to approve the minutes from our last meeting? All in favor?
Aye.
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 Aye. Aye.
All opposed? Say nay. Any abstentions? All right, the minutes are now approved, I believe. And we will move to agenda item number 5. I don't know if Mr. Krueger is here. If he's not, do we want to skip to number 6 and come back to 5?
That would be great. Mr. Chair, I believe you have a question, or at least Darcy Patterson's hand is raised.
Oh, sorry, Darcy. Thank you, Sheila. Darcy?
Actually, that was just my vote for approving the minutes.
Great. Thank you, Darcy.
Thank you.
All right. Again, I do not see Mr. Krueger in attendance right now, so we're going to move from agenda item number 5 to agenda item number 6, and we will come back around when Mr. Krueger joins the meeting. For agenda item number 6, we have a presentation and discussion from the Director's Office, GMU on process and activities from Sheila.
Mr. Chair, can you and the committee see my screen?
Yes, ma'am.
Thank you. So we have been doing a lot of work in communication, and we appreciate all the time and effort of all the committee members and their commitment to the project. One of the things that we wanted to do was kind of take back as we start getting to the final components, kind of take it back and make sure that we're understanding the process and what components go into which level of the process. You will see one common thread through everything, which is this engagement with the Acorn Committee, as well engagement with the surge and engagement with the community, including the public comment that we heard today, which we're so appreciative of the time that those members took, that those individuals took to share their perspectives with us. And so this is just an overview of where we're at in the process, what our next steps are. They kind of work all collaboratively. And again, that common thread is community engagement, outreach, and partnership. Under the community engagement framework, we did establish a substance abuse response working group. Terry Kerns from the Attorney General's office is on the call today, if she wants to add anything additional. And we also established the Advisory Committee for Resilient Nevada. The importance of this committee for the public is because this is to obtain advice and counsel, and everybody on this committee has some sort of knowledge experience related to opioid use prevention, including those with lived experience. The active engagement with the subject matter experts, as well as the community members of the state, as many of us have been bringing those to you at these meetings to talk about the community-based participatory research, talking about the outreach, the engagement, talking about various levels of data and collection. We've also reached out. We've had some meetings with some of the committee members here who have various types of surveillance data that has been integral to the process and to providing to Mercer, and Elyse has been a great support with that. So as we engage with the subject matter experts and those with lived experience, we're really making sure that we're looking at evidence-based best practices and getting both qualitative and quantitative data specific about substance use and opioid use across all regions. It's important to note that we are doing a statewide needs assessment, and we recognize that as we move forward, the state will be supporting either regions or counties in developing their own specific needs assessments if and when they apply or ask for some of the state funding. We really are ensuring statewide participation. We're working to get as much data, research, identified gaps, identifying where we have gaps in data or where we have gaps in information is also very critical, because that helps us with what is important with the system-wide infrastructure versus what might be a program. So we are in the process of the needs assessment development at this point in time. And that gets us to where we're at with the needs assessment. As you know, Dr. Stephanie Woodard has been serving as the intermediary between both the Surge and the Acorn, and she's able to take information from both sides. We've also asked Mercer and other subject matter experts to present information at both committees so that we strengthen the knowledge, we have consistency, we have organization. You know, we also want to really focus on that community-based participatory research, which is those focus groups, and that's being head by the University of Nevada, Las Vegas Office of Minority, or not Office, but Minority Health and Equity Coalition. That also includes the Department of Health and Human Services Office of Minority Health and Equity, in which Tina Dortch is the manager of that. The focus is really prioritization of the needs with community and stakeholder input. And so that's kind of the critical piece. Once the needs assessment timing is for us to finalize the needs assessment at the end of April. So today is a critical meeting when you hear Mercer's presentation to be able to ask questions and really continue providing your input and guidance. After the needs assessment is completed, then we go into the rough time frame of May to complete the state plan development. These are our projected timeframes, but we also want to make sure that we are doing this right and that we are making sure that we have all the input and engagement. So while we want to, our focus is getting these dollars out as quickly as possible to the community to start addressing some of those high need areas. We also want to make sure that your input is heard, the community's input is heard, and that it is collaboratively, that the recommendations are collaborative. At this point in time, we'll be reviewing allowable activities and finalize the priorities, and this is a continued engagement with Acorn and Surge. Again, there is nothing that we are doing or that we are working on in which information will not be presented and information will not be solicited from these bodies. At that point in time, recommendations from the director will be provided from this organization, Acorn. The recommendations will also be provided from Surge. There'll be two separate sets of recommendations. It will be at that level that finalizes the priorities in the state plan. This is advice and counsel, and the recommendations the director considers have to also take into consideration the diverse communities within the state, key system level impacts, and many geographical. Also really important is looking at that lens, that community through a health equity lens, which is also ensuring that we don't leave out marginalized communities. We'll be starting to draft the NOFO, the Notice of Funding Opportunity, which really then is the opportunity for us to, it's really a process, and this needs to be vetted out further in terms of how those monies will be allocated. Many of our partners across the state, the counties and cities, are also getting various litigation funds. So at the beginning, these will be to build up the state, and then we'll be looking to work with those counties and their needs assessments as to where we can all make improvements. In the RFP NOFO development, we incorporate focus populations. It will be a public solicitation. There will be webinars and information on how to apply. We'll have further public outreach, submittal process, and we definitely will do community engagement. This will be done through multiple listservs, through the public announcements, and we will ensure that when there is an opportunity and that the scope of what will be included in the first round RFP or NOFO development, that we will do a wide, really a wide reach of partners so that everyone is aware of the opportunity to apply for those funds. After we get to that part, we'll do the formal evaluations, awardees, standardized data elements. We'll make sure we have program baselines. One of the things that we're responsible for is to make sure that we see an improvement. We'll look at those programs where improvements are happening, and then we'll look at those areas where there might need to be some corrective actions or additional activities to be able to make, you know, kind of change the metrics in the level of impact. As we continue through this, we do the 8 opioid statewide review. We continue with the Acorn updates, the surge updates. We continue to identify gaps in policies or programs that meet the needs. And those policies, any policies that we identify, the search committee is really the organization that is set up with so many policymakers to kind of identify whether that means some regulatory change, or even it could be a bill draft request change. We want to then look at grading activities with state opioid response programs. Again, we do not supplant, we cannot supplant funds. We want to supplement, enhance, grow, and identify those individual programs as well as statewide systems that can be improved. We want to continue our collaborations with the community, and this continues with an impact and quality assurance review. As part of one of those staff members I identified earlier, it's a quality assurance 2 position, and that individual will work with Don Yohey and Dr. Woodard and the team to ensure fidelity of programs, that they're being operated as designed, and that they are working for those statewide goals. In terms of ongoing surveillance monitoring, there is not one thing that can be pulled out. It's going to be ongoing and consistent, focusing on basically our source document, which is Senate Bill 390. I do not believe it's been codified yet, so I cannot give you a statute number as of last week. We have the baseline surveillance data trending, community engagement, public information, again, fidelity, quality assurance, the reporting that we have to do to both the legislative, attorney general, governor's office, and director, as well as the state, county, city level reporting. AB 374 requires that the director's office complete reports that identifies all the opioid funding, whether it's county or state or city, and identify what it is being used for. And that information will be brought back to Acorn as well as Surge to share where the dollars are going on a statewide basis, whether or not it's a direct funding or sub grants. And so at the very end is both myself and Don Yohey's contact, but I open that up to if you have any questions, Mr. Chair, or if any of the members have any questions.
Thank you, Sheila. Do we have any questions? Elyse, I see your hand up.
Yeah, thank you, Sheila, for that really good overview and kind of reminder of the process. So I know that there's money in the fund now, but can you remind me of like the timeline for all of this? And I know that the fund is not something that's going to be like, you know, we're not going to do one NOFO and then do funds from it once. So it's probably rolling, right? Like all of this work is going to be ongoing, but I think I missed the timeline for when kind of these things were going to be moving forward.
Thank you for that, Elyse. I think I can share a little bit. So our goal, we do have several funding streams coming in. Currently, there's roughly $24 million plus or minus in the account right now, but we are doing a 10-year spend plan. And so the first set of funding, we probably would anticipate being able to get out roughly $14 million in the first year. We plan on awards being issued right after July. Hopefully, as long as this process continues to go and we're moving forward, I don't want to say July 1st, because if we need more time to make sure that we have the right level of engagement or get the right level of comments to make sure that our goal is to start evaluating and doing awards if we operate on the current time frame, which would be July of this year. And then it will be rolling, and we will be constantly monitoring. We will also be doing a 10-year budget plan based on the dollars that we anticipate to get. There is an 8% cap, so 92% of all of those funds must go towards those services. Administrative in terms of staffing or those sort of things is the maximum that can be allowed. So that's our plan, to start getting money into the community and start taking your recommendations and making some statewide changes.
Awesome, thank you.
Thank you for your question, Elyse, and thank you, Sheila, for your response. Do we have any more questions for Sheila?
And Mr. Chair, I would just like to note that I did notice that Mr. Krueger and Joan, if you can make Dr. Stephanie Woodard a panelist, both Mark Krueger and Dr. Woodard, if you would like to go back to item number 5, if there's no more questions for me, they are available.
Thank you. Thank you, Sheila. We will move back now to agenda item number 5, which is a presentation and discussion from the Attorney General's Office on the Nevada One Agreement. We have Deputy Attorney General Mark Krueger, and there is a posting of the Nevada One Agreement where our files are available. Deputy Attorney General, are you ready?
I am ready. Can you hear me?
Yes, sir.
Great. Good morning and welcome. Thanks for having me here. I apologize for being tardy, but I am glad you are able to go back to this agenda item. The One Nevada Agreement on the Allocation of Opioid Recoveries is really an important document. It's one that the Attorney General's Office through General Ford promoted, and we went to every single county in this state and every single litigating city and district in order to get to a consensus of how we can fairly and equitably allocate any recoveries. The idea was kind of matriculated when the Purdue Pharma bankruptcy occurred, and we noticed some disparity in the way that the allocations would happen, in that only counties, certain populous counties and the state would receive money from the Purdue distribution when that occurred. That prompted us to say, wait, opioids doesn't care about county lines, doesn't care about city lines. It just literally has impacted all of our residents. And so we went and approached the counties and very happily produced this document that you guys can find on the link. And what this document does is it just says, we recognize that many of us have litigation. Some of us don't, some counties don't, but that there is a need to address opioid remediation in all areas of the state. And that's what you guys are doing in the last discussion I just saw with the presentation about the needs assessment and where the status is. And that's what DHHS is putting together. In the meantime, we provided the ability for us to take away any arguments about how allocation is going to be. And the allocation metrics is included in the One Nevada Agreement on the bottom. We recognized also that certain entities were carrying the lead share of cost. The state of Nevada's case is set to go to trial on April 17th, 2023. So naturally, we are further along than any other case out there. And we've incurred a lot more cost. It's very common in this type of multiple litigation scenarios where the lead litigator costs for all the lead litigators that are pushing the cases forward are taken off the top. So that's what's removed off the top. If there's any other fees and costs, those get removed off as well. Everything except for each litigant's sole contingency fee. That comes off after the recovery. It was very important when we were putting this together that consistent with every single settlement that has occurred so far, as well as what we anticipate will be the requirement of the Purdue Bankruptcy Court and the Mallinckrodt Bankruptcy Court, is to require that any recoveries be used for remediation. So that was important, and we went ahead and wrote that into the agreement as well. And finally, we wrote into the agreement that this is for recoveries. It doesn't impact any particular litigant's ability to go on to trial and recover on their own. The uses for the money have to be used for, as I said, remediation of the harm, risk, and impacts of the opioids epidemic. And for the state, it specifically clarifies that it must go into the Resilient Fund for Nevada, which was created through SB 390. With that, I really can take any questions you like on the specifics of the agreement, or answer any other questions.
Thank you, Mr. Krueger. Do we have any questions?
See, it's always good when you do a great job articulating everything in one, so nobody has any questions. It's perfect.
Absolutely. Thank you for being here and thank you for sharing with us.
You got it. Thanks for your good work.
Chairman Sanchez, did you want to also open it up to Dr. Woodard if she had anything else to add?
Yes, please, Dr. Woodard, would you like to share?
Good morning, Stephanie Woodard for the record. Just a little bit of addition, and thank you, Mark, for that presentation on the One Nevada agreement. So just a couple of things that I wanted to highlight, because the One Nevada agreement does have a direct impact on the work that this committee will be doing. So just as a sort of framework, as the funding is coming into the state, it goes to the Attorney General's office, and then will be allocated to cities and counties based on the One Nevada agreement. And then the state will get its share that goes into the Fund for Resilient Nevada. That is overseen by the Department of Health and Human Services with the advisory committee here. We also require a needs assessment and plan to be conducted by cities or counties, regions, or tribes if they want to be eligible for funds for the Fund for Resilient Nevada. So it is possible that those dollars will actually go down to local jurisdictions and tribal organizations. But in order for them to be eligible for those funds, they will have to go through a similar process with developing a local needs assessment, as well as developing a plan for how those funds are utilized. And then another important part of SB 390 is that we will be monitoring ongoing any additional dollars that are received by the counties or local jurisdictions as they receive those funds. And if there are opportunities for us to identify the potential for supplanting versus supplementing with the ACRN Fund for Resilient Nevada funding, we have a pathway with the counties and local jurisdictions to remediate any of those concerns, meaning that if they're funding certain activities and they need an expansion of those activities through the Funds for Resilient Nevada, we would be monitoring that, but we certainly don't want the Funds for Resilient Nevada to be supplanting any of the local funding that those local jurisdictions will be getting. So just wanted to take a minute to sort of connect the work between the Attorney General's office and the One Nevada agreement, as well as the local jurisdictions, and the work of the ACRN and the DHHS as it relates to the Fund for Resilient Nevada. Thank you, Chair, for the opportunity to provide some clarifying remarks as well.
Thank you, Dr. Woodard. Do we have any questions? I have Elyse with her hand up.
You guys are going to kick me off the committee, and I wouldn't blame you. So I just wanted to test my understanding since I'm not a lawyer. Can I repeat what I just heard back between Dr. Krueger or Mark Krueger and Dr. Woodard? Okay. So what I heard was that the money from the settlements are going to come in to the state, go to the Attorney General's office. The Attorney General will take their costs off the top. Then money's going to go to the counties, which it looks like 38% is what's going to go to the counties in total. I think what I'm seeing from the document. And that money is for, like, let's say a county government then gets that money to do their own programs as a county, right? And then money goes to the state, and then the state is going to be putting like notice of funding awards out and RFPs for that funding by which nonprofits and community groups can apply for that funding, right? So when we say, and when we hear state and counties are getting funding that doesn't leave out our nonprofit partners or treatment providers. They'll be able to apply for state funds. But is that kind of how the funds are going to rain down in the state, AG, county, state, and then those dollars will be applied out?
Mr. Chair, this is Mark Krueger for the record. And if I could answer the question from Elyse, and I've seen you again too, by the way, Elyse. You're almost exactly right. It's very close. I'll go through it just to kind of help maybe make sure that everybody's on the same page. But basically what happened is the pie chart that you were referring to, which identified 38.77% as local government share, that is local government share. However, the 17.37% that's there also goes to counties only. So the 38.77% goes to both counties and cities and a couple districts. The 17.37% goes just to counties, and it's allocated on a different basis. The 17.37% is allocated on a population basis. The other one is allocated on, well, partially on a population basis. And the other one is allocated on a percentage share basis. The 43.86% goes to the state. Now, before we get to the splitting it up, you are correct. The money comes in, and we've agreed as the AG's office to handle receipt of that money and then do all the calculations. The lead litigator costs aren't necessarily just the state of Nevada's. They include other lead litigators. For example, Clark County's case is a little bit further ahead than some of the other ones. There's been some discovery and things like that. So the lead litigator costs primarily take most of those costs that are lead litigators. There are other cases which haven't really had any cost associated with them. And so they're getting a benefit. And that's the theory behind it. You know, we all share among the benefit, the cost to get the ultimate benefit. Once the costs and other fees are removed, then the allocation is done. At that point in time, when the state receives its share, it has to pay a contingency fee, if any. It does that. Or the county receives its share, it pays its own contractual contingency fee if necessary. So just keep that in mind. It's just another little point to make sure everybody's paid off top. And then the residual must be spent for the remediation of the opioids epidemic. Now, the money is coming in over a longer period of time. So the Johnson & Johnson-Janssen settlement is coming in a little bit faster. The distributors settlement will come in over a period of many years. And so as it comes in, every payment that comes in will then just go through the allocation metrics and be distributed. I think, last part, and I'm sure Dr. Woodard will jump in on this as well, but the last piece of your question was, how do people go about getting a portion of the state's money? And the idea and the concept that was set up was that a county or cities within a county should work together, or certain counties as a region should work together. And the reason that they work together is that, number one, it maximizes your bang for your buck. The programs you can fund are a lot fuller, better, and will actually abate this epidemic. It also allows a contact between and a joint kind of work between DHHS and the region, or the counties and cities within that region, to work together to ensure that they're not doing the same thing or doing programs that are mitigating each other, that the programs are actually working and are reaching the people that they need to reach in that particular geographic area, which is why the needs assessments are so important for any particular county or region, as well as the state's needs assessment, because it all mirrors up together. And in this manner, we can actually spend this money in a way that's going to do its best to abate this epidemic. Because if we don't, it's just going to get worse again. And we're seeing that with the trends going back up, as you guys probably no doubt discussed. So I hope I answered that. I know that Dr. Woodard is probably more eloquent in directing the answers to those particular questions than I am, but I think I covered all of your points.
You did. Thank you. I'll just you know, I am like, I don't want to age myself, but like, I'm just young enough to now be working and kind of see how like the state's tobacco settlement funds have supported the community, but I wasn't around when those funds and those accounts were set up for the state. So I don't know if this is a lot like the tobacco process, but so it's different.
Very much. I mean, interrupting you, and I apologize for that, but the reason is that there was a lot of criticism of the tobacco settlement, and we wanted to make sure that the errors that were made in the past, if any, on the tobacco settlement weren't repeated in this. We truly wanted to set this up to get the funds to a place where it's actually doing some remediation of the opioids epidemic and working towards that goal of eliminating it. And then Dr. Woodard had her hand up, and I'm sure she's gonna supply another answer. And I apologize again for interrupting. I just wanted to make sure that was clear.
Chair, if I may.
Please.
Okay. So Stephanie Woodard for the record again. Yes, so just to reiterate what Mark was saying, the reason that states have come out with very specific statutes is to help to avoid a lot of the pitfalls that states had experienced as it related to the big tobacco settlements. And so even so far as that the One Nevada Agreement actually points back to SB 390 and ensures that the funding needs to be spent in accordance with that legislation. So there have been real intentional efforts to make sure that we are weaving together all of the policies that will go into the distribution and oversight and management of all of the opioid funds that are coming into the state. That's the other reason why we were intentional with SB 390 to ensure that should a local governmental entity, be it a region, a county, or a tribal organization, apply for these funds, that we can ensure that there is no duplication. If we fund something in a community to help to fill a gap and that community then has a recovery of additional settlement funds, we have the ability to actually pull back the state's share of that funding. Not to say that we would do so, but we have that availability in the statute. And then we can make sure that they have a needs assessment and a plan that are evidence-based and really align with the state's needs assessment and our plan. So that we can ensure that we have synergy. So one of the biggest issues that I think we all face is that, and we heard a lot of this in public comment, we're doing a lot of really amazing things, but to do anything to scale takes a significant commitment and a long-term investment. And that is where I think we have the greatest opportunity to work with the local jurisdictions and with the state's funding so that we actually get an exponential effect of the funding that's going to the local level. The other question I wanted to answer for Elyse was the opportunity for nonprofits to apply for these funds. The counties and cities who are receiving these dollars likely will also have ways that their community organizations could come forward to request some of these funds. And then of course they are very clearly outlined in SB 390 as eligible entities to receive the funds. We recognize that it can't all go to local cities and counties to be administered at that local level. And that we have some amazing programs that are already doing this work and have been doing this work for quite some time that would benefit greatly from additional funding.
Awesome. Thank you for the good explanation and walkthrough. I have a much clearer understanding now.
Thank you for your question, Elyse. Thank you, Mr. Krueger and Dr. Woodard for responding. Do we have any more questions for this agenda item? I'm not seeing any other hands. Again, thank you for your presentation and discussion. And from here, I would like to move to agenda item number 7, which we have a presentation from the University of Nevada, Las Vegas Minority Health and Equity Coalition on the Community-Based Participatory Research with Dr. Habush and Dr. Marquez, and I guess Jose is not going to be here, but are you ready to make your presentation?
Hi, this is Dr. Habush. Yes, I'm ready.
Thank you. The floor is yours.
Okay, hopefully everybody can see my screen. As you know, when you're screen sharing, I can't see any of you. So
yes,
thank you for thank you. Thank you for having us today. My name is Dr. Habush Soy, and I am I'm the Executive Director for the Nevada Institute for Children's Research and Policy, as well as the Co-Director of Research, along with Dr. Erika Marquez, who's also in the room today, of the Nevada Minority Health and Equity Coalition. And we are here to present our piece of the needs assessment, or where we are thus far, as well as demonstrate how, talk a little bit about the community-based participatory research approach that we use in order to gather some additional data that will be used for the overarching needs assessment. So thank you so much for having us here today. So before we begin, I'd like to take a moment to do land recognition. And we want to recognize that here in Nevada, that we do stand on the land of over 27 different recognized tribes. And these, the main grouping of the four, are presented here. And we'd like to really recognize and honor their stewardship that continues today. And with this recognition, we state an intention to rightfully include their voice and respect them as the 27 sovereign tribal nations of Nevada. So we have the map here that's available on the state too to recognize that, but I just want to take a moment and pause before moving forward so we can just appreciate that and honor that. Thank you, everybody. So I want to recognize that part of this approach that I will go over in a minute is working with our community partners. So I just want to recognize some of the other groups that have contributed. So our coalition and our center lives within the UNLV School of Public Health. We also have been working with a group called Tribal Minds with Track B Exchange. And with individuals with lived experience in order to make this process whole. I also want to recognize that several of the several other organizations that are both participating on this call today, several of the prevention coalitions that are on the call have also been key in helping us to share the information out about our project in order to increase participation. And without the work of all of our community together, this would not be possible. So the purpose really of our piece of this project, it took us a while to really narrow down, but our particular piece was really to understand those with lived experience and make sure that their voices were highlighted in this process, along with all the other data components that are being gathered. And so those that we recruited either currently use opioids, have used in the past and maybe in recovery, or are friends and family of those who use opioids. And our guiding framework for this work was the Community-Based Participatory Research Framework. And so we are going to talk a little bit about what that framework is, and then how we used it throughout our process, and how we see it continuing to be used in the final accumulation of the needs assessment, as well as with the strategic plan. So since I know you have a packed agenda and we have limited time here, I will briefly go over some of the main concepts of CBPR, but I do want to highlight that in the information that you received in the meeting packet, we did create a handout that we tried to make very succinct and hopefully easy to read that goes over the process of CBPR, that discusses some of the research that has been done on CBPR, as well as some of the research that has been done particularly on opioid use and using the CBPR approach. So hopefully, and I'm more than happy to answer additional questions at the end, but hopefully that handout will help explain some of going a little bit deeper to what this approach is. So the overarching concept of this approach is to make sure that we are doing research and data collection and understanding with the community and not on the community, right? So oftentimes, and in the past, we might say, oh, I need data to, apply for this grant or to show this program. And we might go into a community and ask for surveys and do things, but the community may not have buy-in to what that approach is, not know anything about it, but they participate in our surveys and in our groups. And we want to kind of restructure that approach to make sure that they are included in the process from the beginning to the end. And on this, that researchers and the community are at an equal level. So it's not that the researcher is coming in and heading everything and makes all the key decisions, but that the community also has a vested interest in the information that's being gathered. They have a voice in saying how that information is being collected, what's being collected, how that information is being used, and ultimately how what decisions are made in the community with that information. The other key aspect too is that they should have some ownership of that data. So if they say, okay, we want to go on to do other things, they should be able to take the data that was collected in a project and use that for other approaches, other grants, other needs as well, just as a researcher, might do if they own the data. So the idea is that there's co-ownership there. So really looking at these 4 pillars, it is working with shared resources. So both from the researcher standpoint and from the community standpoint, that there's capacity building. So this means, and I'll talk about this a little bit when we talk about our process to do data collection, but when we go out and conduct something like focus groups, we like to do it with the community as co-facilitators. And if they don't have that experience, then what we do is we provide that training. So that way they feel comfortable and they feel like they have the knowledge to co-participate in that process. So again, trying to make that even playing field and participation in all components. The third part, again, that collaborative decision-making. So once the data are gathered, that we go and look at the data together to say, do we agree on what the main points are coming out of the data, and what are we going to do with that? How are we going to make decisions moving forward? They should be a part of that process. And then finally, the empowerment of those community partners. So I really like this quote that I found. What we want to do is empower these communities to address issues for themselves. So it's not that we're some outside entity coming in trying to fix everything and make it, but that we are working together so that we're an additional resource and they have that power to decide what is best for their own community and to have a say and a role in implementing what is best for their community. So hopefully it has the best outcomes for all involved. And I just want to pause there. Dr. Marquez, did you want to add anything?
No, I think you did a great job covering that.
Okay, perfect. Thank you. So now we want to talk a little bit to give you some idea of the piece that we've been working on again with to try to really elevate the voices with those with lived experience. And so here we presented our 4 main methodological processes, which include, well, I'll go through each one. And what I would like to highlight really is how we used the framework of CBPR in each of these, in each of the 4 of these methods. So first was the question development. So when we were coming up with and said, these are the individuals that we want to highlight because we feel like with all of the other approaches, stakeholders, that there was enough avenues to receive their feedback. And we really wanted to make sure we had additional feedback from those with lived experience. So with the question development, we did develop the core set of questions as the internal team, as well as with our state partners, with Dr. Woodard and with Sheila and her team. We looked to develop some of those questions. And then after we narrowed, we went back to our community partners and said, hey, let's go over these questions to make sure that these really capture what you think will elicit the right responses on what we need to move forward with this work. Okay, so there's a couple of different ways that this could be done. Sometimes those initial development of the research questions could happen prior, where we all get together at the table and do that. And while that's ideal, sometimes because of these, the timelines, that's not always possible, but that is ideal. So when we went back to the community and shared these questions, we were very flexible in saying, these can be altered. These are not a final set of questions. We can move around and change any of these to make sure that we are using the appropriate wording, that we are capturing the right content, and that we're talking about the right subjects in order to make sure that when this is over, we have the right information to implement programs in the community that will assist those who are either using opioids or have used in the past, or family or friends, so that collective group. So the next process that we look at is the process to collect data. Now, we use focus groups. However, with the CBPR approach, you can use any process to collect data. The main concept in it is that process is agreed to by your community partners, as well as with the research team, that they think that is the best approach to move forward. So with this community, we did narrow down to start that data collection with focus groups. And while we were in discussion with community partners, we also said, not everybody may be comfortable talking about their experience in a group setting, right? And so we wanted to be flexible in order to respect that privacy. We also offered to do individual interviews with individuals if they were not comfortable in a group format. And that way it would expand our capability and really our ability to meet those individuals where they were. So we could be mobile and collect data in different situations in the community by doing that individual interview perspective. In doing that, we used the same data questions. We just did it one-on-one instead of in a group format. And we think that worked out to the best ability. The next part is with regards to data collection, we did partner with 3 different individuals in the community to help co-facilitate the focus groups that we were doing, and also the actual interviews that were collected were done by community partners. So we worked with them to review the questions, to go through the process and the procedures, and then allowed them, because they had existing relationships in the community, to conduct those interviews. And we think by, again, opening up that approach, that allowed us to better reach our focal population and gather the data necessary in a hopefully more comfortable and approachable format. So the third one, recruitment, we worked with our community partners and facilitators to help recruit those with lived experience. And then we also shared flyers with the larger community. I hope some of you were able to see those and share for the focus groups, that people could call in and express if they wanted to participate in a focus group or if they wanted to have an individual interview. We shared those with the larger community to also to get out to that focal population. So with all of those recruitment methods going on at the same time, that is how we were able to get our sample size. And then I already talked a little bit about the group facilitators and the interview process. So as you can see, we tried to really embed our the partners that we were working with to get their feedback on those different parts of the process. We also switched part of our process instead of sticking with just focus groups to make sure that we were responsive to the needs of the community. And unfortunately, while it seems like we're easing out of the pandemic, when we were planning this process, it was right when we had another surge of cases. And so we called each of the communities and talked with different partners and said, hey, do you want us to come into your community, or would you rather do things virtually? And with the focus groups, that's how we ended up selecting to do a virtual process, because they said, you know what, we really would rather, you know, not come in and stick with that virtual way. And the people who did do the individual interviews in person, they were already in the community providing either services or support, or had connections with those community members to be able to gather that information. So that also played a key factor in what we were able to do and how we were able to move out. So just to give you an idea on our progress to date, this had to be submitted a little bit ago. So we've collected a little bit more data since then, but we conducted 3 focus groups that had a total of 19 participants. We had 22 individual interviews, which now we have 32. And so that increased our total participants to 51. We are still collecting some additional interviews, or attempting to, with our Native partners. It is very important for us to have their voice in the process. And that has been a little bit more challenging just with other commitments and everything. So we want to make sure that we're holding true to that. So we're working to see what else we can do to accommodate, to make sure they have a voice. We did try to make sure within this sample that we have both urban and rural representation, and that we also have representation from different racial and ethnic minority communities. And while it's not as large, we do have representation from the sexual and gender minority communities as well. So here we wanted just to provide some very high preliminary findings, because again, we are just wrapping up our data analysis, but we wanted to point out some things that, that we found so far. So I'm just going to go over those briefly. So first, the harm reduction activity. So under here, individuals did express that they are using existing services. So those are important to make sure that they are continued and available to individuals, but they need more in the community, that they're not offered, you know, widely in different locations, and they're not also offered in all rural areas. Some of the harm reductions, such as, you know, the syringe exchanges and access to things like that, we need to have more of those. They also express that oftentimes that they have to go to emergency rooms in order to obtain care for things like abscesses. And while that one of their suggestions was that they could go to an urgent care, they felt that that would be more appropriate, because while it is urgent and they want to, you know, make sure to get that taken care of, that the emergency room might not be the best situation for that. They also said that that they felt some stigma and some judgment when going into their emergency room in order to receive those resources, like they shouldn't be prioritized because they weren't doing something right and didn't always have the best reception from those who were providing care, unfortunately. The other recommendation was the use of mobile clinics to go to different sites or locations where there might be groups of people who are using, in order to offer care, to offer resources. So those were some ideas that came out. There was a lot of discussion of the medicated assisted treatment, how that was extremely helpful to individuals. However, a big barrier was that after detoxing, many individuals want to go into residential treatment or to access mental health or behavioral health counseling, and it's not available, that there are long wait times to get into residential treatment programs, and they're often not available in their community, and they're very expensive if they have to pay for them themselves in order to be able to be prioritized for some of that treatment. And if they are going through the medicated assisted treatment, or even after they come out of that residential treatment, if they're going back into the same environment that they were in before without any support, that they can see them relapsing very easily. So it's important to have that ongoing counseling and ongoing support in order to and to stay in recovery. The last part is that, you know, some individuals mentioned that veterans may worry about seeking help because they might be afraid to lose their benefits. And while it's to my knowledge that they wouldn't lose their benefits for this, it doesn't change that could be the perception, right? And so maybe more education that it's that's something that wouldn't happen if they sought treatment. So here are some of the challenges. Again, maintaining sobriety or staying in recovery. As they said, support groups are very helpful for those who are using recovery, but we need more support groups, especially those that may be more specific to either opioid use or other substances, although they acknowledge that Alcoholics Anonymous is a great support. And for many people, they go in and that could be a great supplement or just a great support group overall. But they also mentioned that having, you know, additional options would be good, especially they said that sometimes they don't understand for Alcoholics Anonymous that being on medicated assisted treatment, they might see that as also not being sober. So a different philosophy. The second part is that friends and family of those that use mentioned that they have a hard time finding groups and that there are hardly any groups. And you can see in the green, I tried to pull out some of the quotes so far. And here we say, as a parent, I thought I had failed. We didn't have support groups. So you just keep your pain and suffering to yourself. And that they, you know, don't know that other people are going, or not that they don't know, but they didn't have that support of other people who were going through the same situation that could have maybe alleviated some of those feelings of failure and offered better support throughout. Some of the stigma, and I know I'm kind of jumping around again, I want to make sure I'm respectful of time. The stigma impacts, this came up from almost everybody, that there's still a huge stigma, again, going to seek treatment, going to the ER, and that there should be more awareness campaigns about, you know, what does it look like? Who are people who, you know, do use opioids or other substances? What are some of the situations that put them there? So that way they do not feel as stigmatized going to access treatment. And, you know, in the rural communities, that could be, you know, more, it could be harder to try to access treatment without other people knowing it, right? Regardless of HIPAA or other things, you know, there's still the fear that somebody's going to talk, somebody's going to see me go in there. And if that's all they do, if I walk through that door and that's, you know, they're only offering the medicated assisted treatment or counseling for substance use, then everybody knows what I'm there for. And I know that programs work hard to find ways to make it as private as possible, but we also want to work to reduce the stigma so they don't have to feel shame and they can walk through that front door and are supported by the community and not shunned by them. So this is where we go into community awareness and more education. And then we just have some additional quotes in here as well to help really, again, bring out the voices of those with lived experience. And I can tell you, everybody who participated in this, or I should say everybody, most people expressed how grateful they were for the opportunity to participate in this process, to be listened to and to share their story, which was just, you know, very humbling and wonderful that we were able to provide that opportunity, because we felt like we were the lucky ones to be able to listen to them and get their advice, and they felt the same. So that was wonderful to hear. So some of the next steps, we had our data collection ending at 3/18, but again, keeping with our process where we're working with our partners, with those the Native communities, we're going to work a little bit longer to make sure that we have their voice in there. We are working with the data that we've collected so far to put in a final report on April 4th. And then we hope again that this process will continue to go back to the community partners to make sure that they can reflect on the needs assessment as a whole and the strategic plan, that they can see their voices reflected. We're gathering feedback from those who participated as they want to on our summaries. So that's part of our process. We return our summaries to them so they can look and review and let us know if they feel like we accurately reflected. And we hope that approach is carried out through. So thank you very much for letting us present today. And if it's okay with the chair, I can open it up for any questions, or you can let us know what next steps would be.
Yes, thank you, Dr. Habush. Does anybody have any questions? I don't see any hands up, and I don't see anything in the chat. Well, we appreciate you showing and providing us with that presentation, both Dr. Habush and Dr. Marquez. If there are no questions or any comments, Sheila?
Mr. Chair, I just want to just kind of share with all the members right now that this is really an opportunity on these presentations to really engage. And if you, when you're hearing the work that UNLV or Mercer or one of the partners are doing, and you find that you think there's some gaps or some other outreach or some engagement, or you want to make some comments, this is really the time to do that as our partners start finalizing some of those documents. So by not hearing a lot of comments, the assumption after these meetings is that the committee as a whole likes the direction we're going, and it's not suggesting that there's anything lacking. So I just kind of want to make sure these presentations are for you to comment on and that sort of thing. And if they've knocked it out of the park, which I think Dr. Habush did a phenomenal job, then perfect. But just kind of wanted just to kind of reiterate, this is a working group for that engagement. Also, as you go along, and also hear from Mercer today the same.
Thank you, Sheila. And we have Elyse with her hand up.
Thank you. And I know that I've been like beating a dead horse about the bios and the committee transparency, but this is why I think it's hard for our committee to engage. I know people personally on this group that do amazing work with the homeless community, with pregnant and addicted mothers that have worked in public health for years, but we don't know each other because we were never introduced. So I think that, and I know that we have treatment providers on here, so I think that just like pushing the meetings along without an opportunity to like know each other and know what backgrounds we bring to this, I think it's been to the detriment of like our ability to have conversations. So I just want to throw that out. If it feels like, my guess would be there are people that do have comments, thoughts, concerns, or considerations from their own perspectives, but it's really hard to have conversations because we don't know each other. So I'm just throwing that out. I know that the group is probably really tired of hearing from me. I do this every day as my job, so I'm really comfortable in these meetings. I'm really comfortable asking questions, and I would just encourage everybody to continue to ask questions, even if your question feels like it might be dumb or you don't want to ask because you're afraid you should know. So I have some observations, even maybe is what could, of the community-based participatory process. I'm interested in hearing that AA is a main type of support for people in recovery. AA is not treatment, so it was interesting for me to hear treatment and AA in the same sentence because AA is not treatment. And I think that sometimes people think that if I'm in AA or if, oh, they're in AA, they're getting treatment. AA is not treatment. Also, there are facets and functions of AA that people who are uncomfortable with. So if AA is in this needs assessment, the thing that we're talking about expanding to enhance recovery supports, there's probably a problem. My program supports something called Smart Recovery, which is kind of an more of an intensive outpatient type therapy program. So that was one of my observations. Did anybody else have any, maybe if you don't have questions, observations from what Dr. Aboud provided.
And Mr. Chair, if I could just respond, Elyse, everybody on this group was selected and has, lived experience or direct experience. So we have very qualified and intelligent individuals on this committee, as you well know. And we always want to hear from you. We always want to hear from everybody. I think the comments you made right now are the sort of comments that we need to hear in how we are explaining or addressing something. And so, having this engagement and having you engaged with your expertise, and it's not so much what you might know about somebody else's expertise, but everybody individually here is representing a segment of the population. So really, you as a committee member are the voice for that population for which you were appointed. So want to make sure that you're using that voice in these meetings so that it can be incorporated within all of our documents, and so that Mercer and UNLV and Dr. Woodard, Don and myself and all of us are hearing this and incorporate this as all part of the process. So definitely appreciate that. And I did see, and I just kind of wanted to point that out, and thank you for the comment about AA. That two-way engagement is definitely what we're looking for from this committee, and I appreciate you starting that off.
Thank you, Sheila. Karissa, before I call on you, can I go to Dr. Haboush so she can respond to Elyse, please? Thank you.
Thank you, Mr. Chair. I just wanted to clarify that for the comment about AA and treatment. So remember that the slides present, we were just trying to present a brief overview. It's not that, and these were things that came from those who were using those services. So we have to validate that this is what they're saying. I'm not saying this. And they did not talk about it as treatment. They talked about it as part of recovery, but I understand that could be, others' misperceptions that, that it could be treatment, but they did not talk about it as treatment. And what they said is that because there aren't any other support groups, oftentimes AA is what they have to go to. And it's better than not having any support group at all, because it's similar. It's still a substance. It's still use or misuse. And so those processes can help and it can work for a lot of people. But they did recommend that having more support groups specific to substance use, other types of substances, would be helpful. So I just wanted to clarify that it's, I don't know that it's anything is either right or wrong, because different things are going to work for different people, right? AA doesn't even work for all people who have issues with alcohol. Not everybody likes that approach, but that if for those who do and want it, that needs to be honored. And for those who don't and want something else, that's honored too, that we have multiple approaches to meet the diverse needs of our community. Thank you.
Thank you for that clarification, Dr. Haboush. That was perfect, beautiful. Karissa, can you share with us, please?
Yeah, thank you, Chair. Thanks, Elyse. So I also don't have a question, but more an observation of, I think to reiterate even Sheila's point, I'm confident we have a group of experts on this committee. And I think we're all probably very, very, very familiar with the research and what's out there, and even really appreciate, the more targeted community-based participatory research. But I'm kind of in this headspace of what do we do? So what are we going to fund, and when are we going to fund it, and when are we going to decide those kind of things of if we need more support groups, how are we, this committee, helping get those developed and implemented in the community and people participating in them, so that we're meeting the needs of this group of people suffering from opioid use addiction or substance use addiction that is not alcoholism, for example. How are we going to address the needs of the veterans? So I'm just more interested in us getting to the place where we start saying, we know we have all of these issues, and what are the projects we're going to fund, right? And how are we going to start helping our community? Not that we don't need the information, just making that comment that I'm really ready to move forward and start saying, then let's get this group going. Let's fund this treatment organization. We had all of those great groups talk to us in public comment. So how do we start working through with our local communities so we're not supplanting, so we're fully enhancing activities and broadening them, right? And doing more, because that's what supplementing means. So I'm ready to get there. Thank you.
Thank you, Karissa. That was well said. I agree. That's why we're all here. We were all interested in supporting this community and this project, and we all are tied to it in some type of way. So I'm with you on getting to the next point. And I really do appreciate being informed and being given this information and different perspectives from different types of organizations and individuals that work with the population that we're aiming to serve. Brittney?
Good morning, everyone. This is Brittney Collins-Jefferson. I just have, it is an observation and also a question as well. So one, I think it was mentioned that we need more specific support groups. I don't know if those people mentioned what types of support groups they're looking for. I think that would be very helpful. I also felt that the focus group that we looked at, that was a small number of people compared to the population out here that's actually using. I would have liked to have seen that as a larger group. Even though I know it needs to be very focused, I would have liked to see that a lot larger so that we can get a better understanding of what our state needs as a whole. The other thing I noticed is one of the challenges that was mentioned was housing treatment for just for the substance using population. One of the things I know that impacts a lot of people who use substances that need stable housing is the law surrounded around not being an active user. So how are we addressing some of those laws so that these people who are actively using can get housed and also get treatment at the same time and not be turned away?
Thank you, Brittney. I'm not sure if Dr. Marquez or Dr. Haboush have a response to this. If you do, that's great. But I know for myself, I'm a little bit not informed on what type of laws allow or disallow people to participate in inpatient or long-term residential services if they're using. So either clarification from Brittney or response from Dr. Haboush and Dr. Marquez.
This is Dr. Haboush. I can partially respond to that. So one, just for the support groups, it was that they were more specific to either opioid use or other substance use. So like Narcotics Anonymous, things like that. There are a lot less of those than there are Alcoholics Anonymous. And so it was that there was just even something more specific to other substances would be helpful, something that wasn't just AA. So I think the overwhelming thought that came from that is that support groups are critical, access to them, and that people use them, found them to be very, very helpful. So even to having more of those.
Sure. So when we say support groups, I agree with Elyse. Elyse mentioned that AA is not a treatment support group. So are people looking for just community support groups that, hey, you're an active user, I like to bounce off of you, or are they looking for actual treatment support groups? Those are very different. And I think we need to specify what they're looking for when we say support group.
So in the context, I don't think it was treatment support groups. I think it's more community-based support groups outside of the treatment setting. So outside of residential treatment, I should say. That accommodate both.
Sorry.
Oh, sorry, and then I was just going to mention to address the N size. So when you're doing qualitative research, the N's are a little bit different. Oftentimes you're not going to see hundreds and hundreds of participants in that because of the time frame that it takes and the resources there. And this was done in a fairly short amount of time. And not only that, but you really work to get on some of your questions. You talk with people until you're getting the same responses over and over again until you reach data saturation. And then you don't continue collecting data. And while there are, I think there are some nuanced groups that like I mentioned before, that maybe we could get more representation from. And that may be a good thing to look at in the county assessments as well. Is that when we go forward is to collect some of that additional data, because I think, like everybody said, we have a lot of existing data even before getting this data, that this is not a new issue, it's an ongoing issue, and that we've been experiencing for a while. So I think it's really next step taking a look at what are some of the nuances that are missing that might need to drive those last little questions home. So I'm glad that you mentioned that, because I think that's a great role that the committee can have, is to say, these are still the questions that we have, even with the data that already exists. Here is still what we're missing, and the groups that we haven't heard from, at all. And which again is why we want to make sure that we're getting the Native voice in there, because we don't have a lot of data on the Native population with this specifically, and what's needed there. And then lastly, with the housing policy issue, we specifically asked about in the focus groups, what are some of your challenges for policies and accessing resources, not just treatment services, but those resources such as job placement, right, and housing, and any other food supplements, anything like that. What are some of those barriers? And that's exactly what was brought up, is that recovery, you slip in and out, or not slipping out, I'm sorry, oh my goodness, I don't know why I'm spacing on the word, my apologies, but that you relapse, I'm sorry. So relapse is, is part of the process. And so those policies do make it hard for some of those housing policies that say you have to be sober, and don't allow for that process of relapse to occur, are a barrier. And that's why we ask that. So that way, when we go to recommend policy changes in that area, you also have data and lived experience voice to back up that that's a challenge. So that way you can have a strong argument to make those policy changes.
Thank you.
Thank you. And, it sounds like what I heard out of the presentation, the questions and the responses, is that the population is looking for some type of support group, probably, more in the rurals, that isn't a 12-step program, that isn't treatment, but is similar to a 12-step program. So hopefully we can identify something similar. Elyse brought up the smart recovery, and make that something that we look into. What would it look like to help implement support groups in communities that weren't tied to AA, alcohol, or where NA is not available, or that is specifically treatment-based? Ariana, can you share with us, please?
Yeah, thank you. My comments, because I had a previous comments, but Brittney's question also directed me to think of something else. And I also feel seen by Elyse, because she said something around homelessness. And that's where my expertise is homelessness and supportive housing. And I think to Brittney's comment is, I do think we have to look at, and if people want any information, I'm happy to share on that. But supportive housing is an intervention that folks often use for folks that are recovering from substance use disorder, that doesn't require sobriety. It's a housing first model, is a best practice for supportive housing. And so what it really means is that should not be a requirement for somebody to obtain a stable and affordable housing. And the supportive side is that it's coupled with support services. And so I can share that the Nevada Housing Coalition has provided recommendations to the governor, and he's already set aside, I want to say $500 million for affordable housing for our state. And I think where that relates to us is that the folks that we're looking at that need this housing can utilize those services and can access those units when they need to on the affordability side. But what's lacking and that was going to be needed is the support services side. And that's where I think we can come in terms of supporting and funding services and organizations that can offer that support. Because essentially what supportive housing is affordable housing with support services, which is basically any service that an individual needs to keep them housed, which often is related to their recovery and overall wellness. So I just wanted to put that out there and just articulate the importance of that. And I think the comments that were shared in this study really highlight that, and anecdotal information shares that, which is that folks need options recovery housing is excellent for some people. Housing that requires sobriety does work for some, but what we don't have is a diversity or continuum of options for folks when it comes to that. And so supportive housing is one where it has as minimal requirements as possible. People talked about criminal background checks. Those things are not required with supportive housing if it is following all the best practices, and receiving funding that supports that. Most funding requires that you have a housing first approach, which means you can't require sobriety, you can't use felonies or any other kinds of justice involvement as a restriction from somebody obtaining those housing. So I just want to encourage folks to look at that and just share that some of the data really supports the need for that, because from the Clark County PIT count alone, which is the homeless continuum of care, looks at how many people are living on the streets, and they also survey those folks and ask them about what's preventing them from seeking housing. And the 2021 PIT count said that 86% of those individuals identified that they had a substance use disorder. And that's actually over double what was said the year prior, which was only 46%. So it absolutely is an overlapping epidemic. And that I think is worth us really identifying, or at least making sure that we prioritize when we're thinking about what are the needs for our communities, because folks that are living on the streets are also struggling. I know it doesn't ask about opioid use disorder specifically, but I would argue that a lot of folks that identify with substance use disorder, there's going to be, that Venn diagram is going to be a large overlap. So just wanted to share that. Thanks, Elyse, for bringing that out, because yes, I didn't have questions, but I had observations and just comments that relate to that. So thank you.
Thank you, Ariana. Well said. Lilnetra, would you like to go?
Yes, I just wanted to comment that at the end of this needs assessment, would we be able to provide resources where people can access some of these resources? I work for a CCBHC where we provide group for substance use disorder. So those resources are available. I think more people should know about them. We can do it through telehealth, those type of things. So I just think it's important that people know where they can really go to access some of these resources that they are asking for. Thank you.
Thank you, Lilnetra. I think that it's twofold. It's awareness. Do people know that CCBHCs offer these support groups that you don't have to be court ordered to go through, that you don't have to be, I don't know if insurance comes into play for those groups, but if you have insurance or if you don't have insurance, and really, how does the community even perceive, or are they aware of CCBHCs? So I think that there's a part of letting communities know our state is starting to develop these CCBHCs that are specifically meant for, if you don't know where to go, if you don't know what to do, if you're having some type of problem, come here and check it out. So I think like awareness, or spreading the message that they are coming, being developed, being implemented in communities. I don't know if it's perfect in the rules, but something to work on. Pauline, or yeah. Oh, so sorry, 1 second, Pauline. Dr. Haboush, would you like to comment on what was just last said?
Thank you. Yeah, I just wanted to mention that from the perspectives of people who shared information, that it's not always that resources aren't going to be available, or that there aren't current event interventions or resources for everything that was brought up. But again, that they feel like there either isn't enough, it's not available in that area, or that they don't know about it. So I definitely think that awareness should be, part of that strategic plan when you're thinking about, that moving forward. And also thinking about, and people aren't always comfortable going to places like the, CHBCs. And sorry, I don't know why I can never say that acronym right, even though we've been using it for years, so I apologize. But if they're not comfortable going there, what are some of those alternatives? So if there are virtual groups, like how are they getting the information out there to make sure that, that people know that they exist, but that if they're not comfortable going there, where else can they go? Are they housed in churches and community centers where it's not specifically for, a mental health or behavioral health issue, so they don't feel as stigmatized going in? So I think it's thinking about all of, those things together, and that these voices are just, like you said, providing that that background, that yes, and validation that this is something that's needed and should be expanded or increased.
Thank you, Dr. Abush. You know what I see with awareness is destigmatization, like letting people know that it's normalizing that somebody we know is going to have a behavioral health problem, a substance use problem, a mental health problem, and reaching out is okay, and seeking services is okay. It's part of just going through. We're gonna know some people. If it's not ourselves, it's going to be our family or our friends. Pauline, will you share with us, please?
Thank you. For the record, Pauline Sala. It was just an observation because I think I was the one who brought up the adolescent piece last time, to include more. Even when we're just discussing self-help groups, like it's so important for us to separate out adults and adolescents, just because, you know, we don't, it's difficult for us to support our adolescents going to an adult self-help group. Because we just know that their brain development is very different, their issues are different. And so when we're looking at all aspects of interventions, that we remind ourselves to make it adolescent specific and adult specific, because we don't mix those populations typically, and they just need to have different types of intervention. So that was just an observation. Thank you.
Thank you, Pauline. I don't see any other hands up. Did I miss any hands? Did anybody put their hand up and then it went away and I didn't see you? Well, thank you everyone for participating in the discussion, and thank you again, Dr. Abush and Dr. Marquez, for presenting to us today and all the work that you do. If we have no further questions or no more remarks, I'd like to move us to the next agenda item, which I have agenda item number 8, a presentation and discussion from Mercer on the status of preliminary results of the draft needs assessment in compliance with SB 390 legislation, which will be codified in Nevada NRS 433. And Dr. Cantrell, are you ready to go?
I am, thank you.
Thank you.
Got the slides coming up. So as you just said, this is really our update on the report writing process for that needs assessment that we've been talking about so much. So next slide, please. Okay, so I'm going to go over the Acorn feedback that we got last time from you guys, just to kind of review the consolidated version of what we heard that you want to see more of in the report. Then we're going to go over the needs assessment report, kind of its structure and an update on what we've added to the different sections so you can get a better idea of that. And then we'll have a little bit of time afterwards for questions if that's okay with you, Chair. So first, the Acorn feedback. During the January meeting, which is already a couple months ago, right? We received feedback from you that there are additional topic areas that you really wanted to see hit a little bit harder, or that you were suggesting for inclusion into the needs assessment. Now, in general, we could only present so much, so there may have been things that were already in the report, or there may also be things in there that we didn't have information on quite yet in the presentation. So those topic areas, we're making sure that there's more of a regional level breakdown of the data. That's important for statewide, but with the potential for county needs assessments coming too, when counties want to use some of that money for specific purposes, that's going to be very important that they have access to those local stratifications of the data. The primary care and continuity, so in other words, there's already a push to get more MAT availability in the FQHCs and the RHCs. You wanted to see more of that, more about making that low-cost care accessible, especially in rural areas. Wanted to see more mental health disease specific rates for those that are comorbid with opioid use disorders. Wanted to see more juvenile youth and adolescent rates and risk factors hit a little bit harder on that one. Childhood trauma, harm reduction, some more online or accessible educational resources, as well as increasing the accessibility of care, because time and distance can be a challenge in a lot of areas. So that was the feedback categorized and really made succinct that we heard in January. So next slide, please. Next. So the needs assessment, the report breakdown, it's in 7 sections. And the first 1 through 6 are data that we've collected and that the state has given us that we've really consolidated to show what the background, the opioid impact is, to show what kind of polysubstance use is going on, co-occurring conditions, suicide, to look at the risk factors both at a systemic level and individually, and as well as looking at some best practices because it's very important. And then finally are the recommendations. And so what we're going to include, or what we're including in each of those sections, is making sure that we address the disparities, inequities, and access where we have that information available, which includes across geographic regions, across special populations, race, ethnicity, SES, wherever we can find those differences in people's access and impact. We report on those as well. So next, please. Excuse me. Okay, so the first section, we've shown you some of these before. There's a star next to it. We've already discussed some of these in the previous meeting. So again, the background section is just the history for your state and the relevant legislation that leads to the report. The methodology includes a scoring rubric that Mercer has that has been applied to Nevada's recommendations to help you to prioritize them. So we score things so that when you're comparing two things, you get an idea of how they might look against each other. I'll talk a little bit more about that in a second. And then the third section, we really start the meat of the report with the opioid impact. So overdose deaths, health equity. We've talked about before with you guys that there's a lot of information we really want to know to define a problem, right? But sometimes that data is not available. Sometimes it's inconsistent across sources, and sometimes it's not robust. There's just not enough of it to really draw conclusions. So where we found that to be the case, we also make recommendations and note that there is a gap in the data. So if it's not there and we can't find it, then we call it out as something that might need to be paid attention to in the future. So additional Acorn topics that will be included in that section 3 are the regional level data stratifications and more attention to the youth and the child and adolescent rates and risk factors. Okay, next slide, please. So section 4 covers all those things that are kind of on the edges of the opioid epidemic, that polysubstance, the co-occurring conditions, the suicide impact, the things that don't often get the most attention as the actual use disorders and treatment, but the things that are very important to addressing it. So we go over the rate of polysubstance, the co-occurring behavioral health and physical health conditions, because those are important as well. And we also I've hit a little bit harder on the suicide for people who have OUD or substance use as a contributing factor, because we know that's very important. And with the Acorn suggestions, we have made sure to include those mental health disease specific rates where they are available for that comorbidity between opioid use disorders and different mental health disorders. Section 5, as we said, risk factors are at that system level and that individual level. And the suggested topics that Acorn made in January that will go in, or that are in that, sorry, I keep saying will go, but we've already submitted a draft, first draft anyway. The things that you guys have talked about that are going to go in that risk factor section are that primary care and continuity of care, making sure that's available in those situations and that people are doing screening so that sometimes people aren't getting treatment because they haven't been screened and referred. Childhood trauma. So there's a very large ACEs section, that adverse child experiences, that really does predict a lot of substance use and other adverse outcomes later in life. Harm reduction services, that again, the educational resources and accessibility of care are all also included in that risk factor section, because each of those fall into either a systemic risk for the opioid situation getting worse in the state, or to individual risk for people falling into opioid use disorder or falling out of recovery. Next slide, please. Okay, so section 6, again, as they mentioned earlier, the prevention is incredibly important. And so there's a whole section just on the Johns Hopkins recommended best practices with the recommendations that have been made specifically for Nevada, because it is most important to focus work and resources in those things that have some proof that they have worked in the past or that they work in certain populations. Section 7 is going to be is the largest section. It is all the recommendations. We have a ton of recommendations there. They go from prevention of overdoses to prevention of a opioid use disorder. They address disparities in healthcare, prevention with youth, with adults. It just covers a lot of areas, and we have that categorized as well. Let's see, next slide, please. Okay, I want to go back to actually and say that when it comes to those recommendations, like I said, at some point we'll be able to come and present to you guys a scoring rubric that we use for the recommendations so that you can compare across different types of recommendations as to which ones are more critical, will serve more people, will fill a gap better than others, so that then it can help you to make better recommendations as to which ones you want to prioritize in the state plan. So any questions about our progress so far?
Thank you, Dr. Cantrell. I have Elyse with her hand up.
Thank you, Chair. Yep, so I don't have any questions, more just observations, I think. So when we're looking at accessibility of care, it looked like the metrics you're looking at are time and distance. But I'm thinking I also want to make sure that the assessment is looking at coverage and insurance. So specifically people who are uninsured and uninsurable, which would be those people that aren't eligible for publicly subsidized health insurance. And then if any information can be gleaned on people who may be underinsured, where they have a really high deductible or lots of out of pocket, and that inhibits their ability to get services. I think given what Ariana mentioned today on the point in time count with people reporting having a substance use disorder who are homeless, that might be something we also want to look at as part of the individual social determinants of health. And then I don't remember what we looked at for the justice involved. I think you had it categorized under a social determinant of health, but if there is something beyond arrest data, maybe if we can get data from the jails and the prisons, maybe for, I don't know if they've got treatment data or what, but maybe people that are coming into jail that are screening for suicide or something else would be helpful. Thank you, Chair, for the time.
Thanks.
Thank you, Elyse. And thank you, Dr. Cantrell, for the work you and your team is doing and have done so far. We all look forward to seeing what's next. Does anybody else have any questions or comments in regards to Mercer's presentation? Cornelius, please.
Thank you, Mr. Chair. Cornelius Sheehan for the record. And just following up on what Elyse said, a portion of it with regard to insurance coverage, the scope and types of services covered under insurance is very interesting as well. So for instance, is family work covered for folks?
Right.
Be interested in that.
Okay.
Thank you.
Thank you.
Thank you. Great point. Does anybody else have any comment or question or direction that they would like the Mercer team to look into? So far, it looks like the direction that things are going and what you'll be bringing to us as far as recommendations is looking pretty good. I'm excited about it. Thank you again, Mercer team. I'm just going to check to make sure we have I have an attendee that is in chat with a comment. Do we say that for public comment at the end, Sheila? Or is that right now?
Public comment, sir.
All right, we will address Katrie at the public comment section. And does anybody else have a comment or question for the Mercer team before we move forward? All right. We will move to, again, thank you, Mercer team. We will move to agenda item number 9, which is a presentation of calendar for the ACRN meeting dates and discussion of upcoming presentations by Sheila.
Thank you, Mr. Chair. Sheila Lambert for the record. The next day of the next meeting, so that we can get on your calendars in advance, we did what we heard what the council members wanted. So we attempted to identify the next 3 meetings so that, and we'll try to keep them as far out scheduled as possible. On April 20th, we already have scheduled Tina George, who's the manager for the Office of Minority Health and Equity, and she will be providing the tool to support the Acorn community in looking at the needs assessment through a health and marginalized community lens. So that will be on April 20th. In addition, Mercer will be bringing back the needs assessment at that time. It's going to be a pretty full meeting for the April. Is there anything else in specific, Mr. Chair, that you would like to have at that meeting?
I'm not sure if we have, or if this has already been included or talked about, but again, if we could move towards those bios, kind of getting us more connected to each other. I'll just bring that one up one more time for Elyse. If there's room in April, that'd be my only suggestion. Is there anything that I'm missing?
So, Mr. Chair, if you would like, in public comment today, everybody can go around and introduce themselves if we would like to do it that way, or if you want to wait for written bio, it's certainly up to you.
I'm sure there's different preferences among the group, but I just remember knowing a little bit about each person based off of how they were assigned to the committee, like a person that works in the juvenile justice system, a person that works with a community-based program, a person with lived experience. So I have, I'm pretty confident with what we have so far. If the committee would be fine with taking some of the last minutes that we have during public comment to give a brief verbal bio, I would be good with that, but I don't want to have anyone not get to provide a written bio, if that's what you'd like.
We're going to, so the written bios will be done. It was just in terms of how quickly this process is moving. If you wanted to do that during public comment, I was just opening that as an option. I'll be working with Joan, and Joan will start, working on those individual bios.
Okay. Yeah, I think we might as well close it out with that. We have covered right now that we have our next meeting set, and that is the second to last item on the agenda before our final public comment. Does anybody have any question before we move to our final agenda item?
I have a question, Chair. Karissa, Loper, I didn't hear, do we have a date for the meeting or just an agenda items?
No, the next 3 dates, I'm sorry, Mr. Chair,
You're good.
Karissa, on the agenda, it says April 20th, 2022 at 9 a.m. The next meeting is May 18th, 2022 at 9 a.m. And then the subsequent meeting will be June 15th, 2020, 9 a.m. Our goal is to keep those meetings out as far as we can, 90 days, so that so all the committee members are able to forward plan as much as possible.
Thank you, Sheila. I wasn't actively looking at the agenda, so my apologies.
That's what I'm here for.
All right. I will then move us to our next agenda item. I'm going to open up agenda item number 10, public comment number 2. And I have 2 people that would like to speak at this point. Make it 3. I am going to post in the chat to everyone that we want to avoid repetition and also limit our comments to 3 minutes so that we have time for people to share. If there's multiple people that want to share, I'm going to start with Katrie Saunders. I don't know if I'm saying that right, but I think so. Are you available and interested in sharing?
Yes, definitely. Thank you so much. I really appreciate your time today. I won't be repetitive. Just to touch on a few things. I grew up here in the state of Nevada. I've worked in the travel and tourism industry as well as the cannabis industry. I have a large experience of talking to people on a day-to-day basis, not only from the travel agent perspective, from when they buy their tickets, when they book their planes, from being a local here in the state of Nevada, from growing up, from going to preschool, from elementary, junior high school to high school and college. I've talked to hundreds of thousands of people, just more than 22. I really appreciate the doctor's perspective. And though she's right on things, I've literally have real life lived experience from being a travel agent, from being in the cannabis industry, from being a medical cannabis patient advisor, from medical to retail. I've talked to hundreds of thousands of people. I've seen their pain. I've helped them get off opioids. I've seen what medical cannabis and education of your endocannabinoid system and having a major support system. I didn't have anybody when I got out of prison. I went to prison for getting set up from helping patients in the state of Nevada for a very small amount. My fine was $100. As 11 years later, I'm still being affected by the war on drugs from me switching to medical cannabis to save my life so I wouldn't die from opiates. Then I got into a car accident when I was on pretrial, and that landed me back on opiates. I worked really hard to get off opiates. And I'm really thankful for the past 8 years that I've been able to turn my life around and go to school and be there for my kids. What I am really concerned about is my voice being left out when I speak out about them changing the law to exclude felons after I've helped protect over 800 patients from federal prosecution. I've helped grand open the Source Nevada. I know I've helped make over $100 million. Yet here I'm struggling today. I'm living at my mom's. My kids live with their fathers. I'm in a disarray. Everything I've done, I've had to do by myself with my own resources. My foot's broken. I do DoorDash. I do whatever it takes that I don't have to ask for resources from help. And I believe my voice could be integral in implementing real life programs that are going to help people that have been affected, not just statistics, because things need to be done and there doesn't need to be much more talk. There needs to be action. So I'm here to help any way possible. And I really appreciate everyone's time today and sharing their input and the data and the resources. And I just would like to move forward to help start healing some of the situation and the pain that people have been experiencing and ongoing. Thank you for your time today.
Thank you, Katrie. We appreciate you speaking out, speaking up.
Thank you.
The next person I have for public comment is Gwen Taylor.
Yes, thank you, Chair. My name is Gwen Taylor with ACCEPT. ACCEPT has been implementing positive action and evidence-based program approved by SAMHSA since 2002. We implement an elementary positive action program for 4th and 5th graders and a teen program at the Washoe County Juvenile Detention Center and other community locations. Research has shown that positive action programs have improved outcomes related to the use of alcohol among high school and middle school students. Prevention works and is a vital piece of the continuum of care. Effective prevention strategies can minimize disease burden by delaying the start of use, reducing problematic use, reducing the harms associated with alcohol and illicit drugs. Starting prevention education in elementary school is critical. Since the Positive Action Prevention Program addresses risk and protective factors common to a range of behavioral problems, they produce positive outcomes, not just in drug taking, but also reducing aggression, early pregnancies, drunk driving, and improving mental health and educational outcomes. Accept is a Black woman-owned led organization. Our target audiences have been African Americans and minorities since 1995. However, we do not discriminate with our services. For the past 20 years, minorities have made up 75% of the students we teach for the Positive Action Program. Last quarter of 2021, our enrollment was 86.2% minority students at one of our local elementary schools. Accept has enjoyed a relationship with JTNN since 2002. We work with Title I schools and the Team Up after school programs. Title I is to even the playing field for low achieving children, high poverty children, limited English proficient children, children with disabilities, and Indian children or neglected delinquent children. The Youth Risk Behavioral Survey is paramount in helping us know the drug and alcohol trends every 2 years among middle and high school students. Prevention efforts are data-driven by the state of Nevada. The organizations involved in this effort utilize a structured evidence-based approach to prevention for a broad and purposeful impact in our community. Prevention aims at mitigating trauma and supporting all people in living meaningful lives. Per CDC, the 2017 YRBS survey stated over 1 in 4 students, 28%, reported they had been offered, sold, or given an illegal drug on school property during 12 months during the survey. With the legalization of both medical and recreational marijuana over the past 2 decades, student responses may not even include marijuana as an illegal drug. Regardless of the technicalities, nearly 30% of Nevada students had the perception of access to illegal drugs on school property at a rate that is significantly higher than the national average of 19.8. The 2019 YRBS data stated 37.3% ever used marijuana, 19.8% used marijuana in the last 30 days, 26.1% used alcohol in the last 30 days, and 15.1% rode in a vehicle with someone who had been drinking. I lost 2 siblings due to drug abuse related murders, and I wish we would have had the Positive Action Drug Prevention Program when we were growing up. Thank you.
Thank you, Gwen. Thank you for sharing with us. Thank you for bringing your perspective to the group. I have 3 more people with public comment, starting with Lisa Lee, then we'll have Esther Quillisi, and we'll finish with Dan Musgrove. Lisa, are you available?
Yes, good morning. Thank you, committee members and Chair Sanchez, for the opportunity to speak today. For the record, my name is Lisa Lee, and I'm a woman in long-term recovery from opioid use disorder, a certified peer recovery support specialist, doctoral student in public health, and a human services program specialist for the Washoe County Human Services Agency. I also sit on the SURGE and chair the Nevada Interagency Council on Homelessness to Housing. I'm speaking today to thank Dr. Habush and Dr. Marquez for their presentation. Their research parallels the research that Dr. Swigert and I completed last summer with the Nevada Public Health Training Center with people who use drugs and people in recovery across the state. In that study, we found, and it was a qualitative study, we found that people initiated and maintained use largely due to experiences of trauma, and often mentioned the value of peer-delivered services that support multiple pathways of recovery, as well as harm reduction services across the state. I'm wondering if various researchers can collaborate to discuss our findings and avoid duplication, which may help inform the work that Mercer is doing. Thank you for your time.
Thank you, Lisa Lee. We appreciate your perspective and bringing that. And that's a great question, right? How do we better connect people that are doing research on the population and the issues that we're looking at to help include that in the direction that we'll be giving or advising for the funds that will be distributed. looks like before I take Esther and Dan, I'd like to call on Dr. Haboush to comment.
Hi, this is Amanda again. I just wanted to mention too, and thank you so much, Cecilia, for your comments, that before we went forward with our project, I actually did meet with Dr. Wagner, and we talked about our questions in her study. So that way we tried to build upon and gather additional data. And when I do my final report, we're actually going to compare some of that in the discussion. That way we can take it as an integrated approach and use the existing data to make sure that we're not, that we're building on work that has already been done. And I'm sorry I didn't get a chance to connect with you as well before we move forward, but I just wanted to put that out so you know that we do live in silos a bit, and so I know we definitely need more work to do as a community to make sure that we are being more collaborative, but that we work connected in this work.
And Dr. Haboush, I just wanted to make sure that you recognize that Lisa Lee was talking about Dr. Swigert and not Dr. Wagner.
Oh, my sincerest apologies. I apologize.
We can now move to the next public comment, and it looks like it'll be Esther Quillisi. Esther, are you there? Esther, if you are there, you are on mute right now. If you'd like to unmute yourself and...
Hi.
There you go.
Thanks. Chairman Sanchez and committee, my remarks are very informal and they come a result of listening to your comments from today, which I find actually very enlightening and also uplifting. Such good work is happening. I am the CEO of Vitality Unlimited, and Chairman Sanchez, you made a comment about the rurals, and I just would like you to make a comment that Vitality Unlimited operates 4 CCBHCs in the state of Nevada. There are 16, and we operate 4 of them, and we operate 3 of them in rural areas, or Elko County is a rural frontier area. And we are Complete Behavioral Health. There are 2 other agencies, I believe, that operate CCBHCs in rural Nevada. And this, I believe, we're part of the solution that will go forward into the future, where our efforts are highly successful. We serve cradle to the grave. Our youngest participant is 3. Our oldest participant in the system is 94. We address housing needs, substance use disorder needs, mental health. What I believe is so important is we do wraparound, which includes medication-assisted treatment. Vitality began as an addiction treatment program, and we are now, of course, it's called SUD. I would assure the committee that we don't require people to be sober to come into treatment. That's why we have detoxes. We have 2 treatment centers, one in Carson, one in Elko. And Vitality's been in business 50 years, but we do not require people to be sober to come into treatment, because that's what detoxes are for. And we do embrace medication-assisted treatment as a recovery option. It isn't for everybody. Not everybody wants medication-assisted treatment. Those that want to do talk therapy alone, we offer that too. I would like to again say that I appreciate your efforts. And Elyse, you have really helped to clarify some of what was questions for me in my mind. So you go, girl, and you continue to ask the questions that I think are so clarifying and so important. And I appreciate all of you giving your personal time and professional time to this committee. And thanks again. This is the first time I've attended it. I've had staff who've attended it for me. And I'm glad that I attended it today because it's given me a whole lot better idea of the work that you're doing. So thank you, Chairman Sanchez and committee, for allowing me to present my remarks to you today. As I said, these are really very informal, and hope to hear more about it in the next meeting in April. And thank you again.
Thank you, Ms. Quilty, for showing up and speaking with us today. We appreciate it. You know, hearing Esther speak about vitality, it brings to mind the importance of, like Lee said, peer support specialists in treatment, and really the need for an armory of peer support specialists across the state. And then it also brought to mind that there are some disparities, some inequities with people who speak Spanish across the state and accessing inpatient services. Sometimes if a person's primary language is not English, they're not able to access services because they're Spanish speaking first. Now it's more likely that they could get services through a state or a federal or a county organization, but when it comes to nonprofits or private industry, it seems to be a pretty big issue for second language Spanish speakers. And for the next public comment item or person to speak, I would like to call Dan Musgrove, and then I have one more after that, Eric Smith.
Thank you, Chair Sanchez. Good afternoon, everyone, or good morning still. Again, thank you for the opportunity to provide public comment. My name is Dan Musgrove. I'm a government affairs consultant for Strategies 360, represented a lot of healthcare clients, but in my free time, do a lot of volunteering and work on a number of boards and issues related to both mental health and substance abuse. And I just wanted to reiterate a couple of things that Deputy Attorney General Mark Krueger made, and I apologize. I don't mean to be repetitive, and I certainly don't want to be. At the same time as this meeting, the Legislative Interim Committee on Healthcare is meeting and talking about children's mental health and substance abuse and those issues. So he talked about how the One Nevada settlement, includes both the state and local governments. And one of the things that he said that was so crucial is that we need to work together. That so many of the local jurisdictions who get their own settlements need to work collaboratively with this committee and the state so that we do provide more bang for our buck. We so often in these types of communities, we work in silos and everybody doesn't know what the other entity is doing. And I just want to make sure that this committee, the Mercer group, does their due diligence in working with the local governments who don't always know that committees like this take place. SB 390 was very important, as Dr. Woodard said, to kind of set the stage to allow that we do in fact utilize and maximize the dollars that come into Nevada. And we want to make sure that we have a true impact on our citizens statewide. And so again, I just want to reiterate the importance of working collaboratively, and if local governments and municipalities aren't reaching out to this committee and the consultants, then we need to make sure that we reach down to them so that we get a true picture of how communities need to work to spend this money. So thank you for the opportunity.
Thank you, Ken, or Dan, thank you for sharing with us. I have one more person for public comment. I have Eric Smith.
Hello, my name is Eric Smith. I'm the Chief Juvenile Probation Officer in Lyon County. Thank you, Chair, for this opportunity to lend my support. Calling in to kind of voice my support for prevention and diversion. Recently here in Lyon County, we just did our first Youth Stepping Up initiative. We used the intercept model to kind of detail the different gaps that we have in our community. And one of our strengths in Lyon County is our ability to collaborate with our coalitions to government and schools and all entities therein. a great deal of our time was spent in the 0 and 1 area for that prevention and diversion of our youth. And we're really working hard to try to prevent our youth going to higher levels of care. We see a disproportionate number of youth who do end up in higher levels of care being sent out of state, and if sent out of state, not being able to connect with their family or receive appropriate care returning to the community, which oftentimes lead to further involvement and then higher levels of care. So I would ask you to please consider this, and thank you for your time.
Awesome. Great points, Eric. Thank you for sharing with us. Well, as of now, oh, there's somebody there?
If I may,
yeah,
Mr.
Sorry.
Cornelius. No, thank you. I just wanted to recognize what Mr. Smith offered. It squares with my experience, and it's one of the reasons that I'm on this committee is that experience. So I want to thank him for those comments and offering that perspective. Thank you, Mr. Chair.
Thank you. Thank you for sharing. As of now, I have no more hands for public comment. At this time, we have a little bit more time open in this meeting. Sheila had suggested that we use a little bit of the time, since there is no one else interested in speaking as part of public comment, to kind of give an introduction of ourselves to each other in the committee. Does that sound like something we want to move forward with? I have nobody saying no. I have nobody saying yes.
I'm
Karissa?
for it if everybody else is for it.
Yeah, let's do it. I'm gonna oh, maybe I'll start. I'll start at I'm on the participants list on the panelist side, and it shows myself as the top person. Probably shows each one of you as the top person also. But I'll start us off, and then I'll move down the list and call each person individually. My name's David Sanchez. I'm a person in long-term recovery. I work as a resilience ambassador / crisis counselor for the Nevada Resilience Project. I have experience working with the local county human services department as a community health worker. I'm also a certified peer support specialist, and I have lived experience to bring to the group, as well as a ground level perspective of people that are still struggling with substance use and mental health issues. And I'm interested in helping normalize the experiences that our family members and loved ones will go through, and that some of us have been through ourselves, just to make it more available for people to be interested in asking for help. That's all for me. I have, we heard from Joan earlier. She's new to the team, but we heard from Joan. The next person I have is Cornelius Sheehan.
Thank you, Mr. Chair. I come to the committee. I'm a clinical social worker in Northern Nevada in Reno, and come to the committee with professional and lived experience. Professionally, what was most relevant and interested me most was in around 2004. I worked with, I think it was then Captain Sheriff Haley. I'm not a law enforcement person. I was coming at it as a professional to develop in-custody treatment programs at the Washoe County Detention Facility, because one of the patterns I'd noticed as a treatment provider, colleagues and I had noticed, is that people were rolling out of jail. This speaks a bit, and I'll be brief, this speaks a bit to the aftercare issue and the continuity of care issues. People would roll out, they would go back to same environments that were problematic before for them, and they didn't have support or anything set up. And they didn't have relationships with treatment professionals while they were in custody, when trouble was starting to occur. So it was really difficult for them. And frankly, some of what was set up with their court mandates made it nearly impossible for them to comply with treatment requirements. And then they were recidivating, if that's the way to put the word, as a result of those things. And it was not only, of course, really damaging to the individual and their constellation of family and friends, and kin, but it was very expensive for the community to go through the process of rearrest, reincarceration. So the programs grew from one men's and one women's treatment program in custody in 2004 to over 20 in 2011. And in 2011, I stepped away to more of an advisory role for the program. But in short, between that and a lived experience around opiates, that's what I hope to bring to the committee. So I'm very, very privileged to work with all of you. Appreciate it.
Thank you. The next person on my list is Brittney Collins-Jefferson.
Good morning or good afternoon, everyone. I'm Brittney Collins-Jefferson. I am also a licensed clinical social worker. I had a licensure in drug and alcohol abuse counseling as an intern. I decided not to renew as I'm going to test very soon. So I will have that license hopefully by this summer. I am the owner and founder of Restorative Health and Life. We're based in North Las Vegas, where we provide outpatient counseling services to like individuals, couples, families suffering from mental health and or substance use services. We use more of a holistic approach there, you know, where we base it according to their need. I also have professional and personal experience as well, where my ex-husband dealt with substance use. And so I bring both to the table for this group.
Thank you, Brittney. The next person I have is Cecilia Maria.
Unmute. Hello, my name is Cecilia Maria, and I am here, I imagine, for two reasons. One, my late husband was a substance abuser, specifically opioids. And following that, my mother was put on home hospice, and was visited weekly by healthcare professionals who would leave opioids for her to take to manage her pain and her discomfort. I don't know that they administered them because at the time I was still working, but when she passed, I did find opioids in her pantry. An entire shelf in her pantry was full of prescriptive opioids that were brought to her because she wasn't leaving her home. Her freezer was pretty well packed with similar drugs, and some in liquid form in the refrigerator. And I was just shocked. I couldn't imagine how someone would continually bring the same supply to her when you see it wasn't being used. It was there, it wasn't necessary, but it kept on coming until finally, after work one day, as was my custom, I came by to see her, and she was just unconscious, lying on her sofa. And I had no idea what she had taken or how much. So that was pretty devastating to me. And I imagine that's the reason I'm on this panel or on this committee, to share those two experiences. And I thank you for the opportunity to share that with you, because I know she was not alone in this. Thank you.
Thank you, Cecilia. And thank you for sticking with it and showing up and being a part of this group. The next person I have is Darcy Patterson.
Thank you, Chair. My name's Darcy Patterson. And I bring lived experience as well. I'm a person in long-term recovery, And I also am the mother of Kirsten Yamaoka, who died March 1st, 2017 of an overdose of heroin right here in Reno, Nevada in Idlewild Park, found in her car alone after battling with substance abuse disorder for a couple years. Ever since, I've been an advocate to put the voice out there for those that can't speak anymore, and also support moms that are going through the same grieving process that I'm going through, support other moms and dads who need a group to come to share their difficulties and questions about substance use disorder and how to kind of navigate through it. I am one spokesperson for Wake Up Nevada, and I do a lot of outreach with Wake Up Nevada for resources. I know someone talked about resources earlier, and I think it's very important. And I think our community is now coming together in Northern Nevada to get those resources out, and I'm very pleased with that. The Washoe County Sheriff's Office is having one coming up May 21st. I am passionate about saving parents from my horror. I've seen collateral damage in many different ways, not just from losing a child, but from, becoming in debt because of the fact that you're having to fund your child's treatment, it not working, overdoses, car accidents, funerals, burial, many of those things that I don't know that everybody really thinks of. There's a lot more, but it's collateral damage that really isn't always talked about. So I think that's probably why I was picked to be on the committee. I'm very pleased to be here, and I'm very interested in all of the speakers and ideas, and I'm very excited to be able to be a part and hopefully form some understanding and some direction for the monies that are coming into our state. Thank you.
Thank you, Darcy. It looks like my next person is Dr. Farzad Kamyar.
Good morning, close afternoon, everybody. Yeah, Farzad Kamyar here. So I'm a physician, board certified in psychiatry and addiction medicine. Currently working at high-risk pregnancy centers, the director of collaborative care, where we started the mother program specifically to treat pregnant and postpartum patients with opioid use disorder, co-occurring mental health issues as well. I'll give you a little tidbit about the lens that I'm sort of going to bring and use to scrutinize the information that's presented to us to guide like recommendations is basically what we would call, evidence sort of based or evidence informed. For those that aren't familiar with this, it's basically, what is out there, what studies have been done, what data do we have to help inform this decision or help inform this recommendation that we're making. Because oftentimes, and I'll sort of call out not so much mental health, but yeah, mental health, but mostly substance use disorder treatment as being, oftentimes not evidence informed, sort of anecdotal and, hey, this is what we had 50 years ago, so this is what we should be doing now, has crept into that part of treatment or that part of the community. And furthermore, sort of looking at this from a parity basis, parity meaning that physical health should be treated the same as mental health. And again, this is something that just is lost upon us when it comes to mental health and substance use disorders. What I mean by that is, we formally long story short, we formally describe substance use as a chronic disease, right? So I approach it using the chronic disease model, which says that our treatment for substance use disorders, including opioid use, of course, should be no different than our treatment for other chronic diseases. I sort of always tend to use diabetes as that analogy or that similarity, right? So I ask that you sort of view information presented at you and what you might think would work or what we should recommend through that lens of, hey, is this how we would treat someone with diabetes or something along those lines? And I think time and time again, you'll hear instances where, that's interesting. That's kind of not what we would recommend or not what we would say to treat someone with diabetes. It's awesome that we have all of these experts providing us with this guidance. It's great to come from a place like looking at the Johns Hopkins model, what the work with the presentations that have been delivered today, to sort of set these guiding principles on where are we going to base this foundation in. But again, just looking through a couple of lenses of evidence-based, evidence-informed. Does this stuff truly work? What works the best? What's the most effective? Silver lining here is that substance use disorders are actually really effectively treated, which is awesome. And specifically opioid use disorder, which is kind of the purpose of what we are, right? Is focusing on that. We have fantastic treatments. You've heard about a few of them today. So we should be able to start heading in the right direction, but just getting there sort of appropriately.
Thank you, Dr. Kamyar. The next person I have on my list is Elyse Monroy.
Thank you, Chair. My name is Elyse Monroy, and I'm the program manager over the state's Overdose Data to Action program. So my program is the main source of CDC funding for fatal and non-fatal overdose reporting. So we do a lot of data and surveillance work. So I serve the surveillance category, but I have worked in opioid and overdose work in the state for the better part of, I guess, 8 years now, which is wild. But I was Governor Sandoval's policy analyst when a lot of the state's formative policy work happened. So I helped champion Senate Bill 459, which expanded access to naloxone and established a Good Samaritan law. And then I had the great privilege and honor to write Assembly Bill 474 and get that passed through the legislature. So my career has grown with a lot of the state, and I as a person have grown with a lot of the state's opioid work. I see the Resilience Fund as being a way to fundamentally transform how services are being delivered and funded. So I was honored to get an appointment. I think one of the challenges, right, is that most of our public health initiatives and behavioral health initiatives and mental health initiatives in Nevada are grant funded. And when we get grants, if you haven't had the pleasure of working on a federal grant or a state grant, it comes in a box, and we have this money in this box and this money in this box. And these boxes are for these people and this service. But we know that programs aren't administered like that, and needs in the community are not met like that. So I see the settlement dollars as a way to really help braid funding in a way that we really have historically never really been able to. So I'm really happy to get to be part of be part of a group that helps to make recommendations, and most importantly, to learn from all of you. So thank you.
Thank you, Elyse. The next person I have on my list, I believe, is Jessica Barlow.
Good morning, Jessica Barlow, and I am also very honored to have been appointed to sit on this committee. And I come from rural Nevada. I'm born and raised, basically. Born in Bishop, California, but lived my entire life in Pahrump, Nevada. And I bring to the committee long-term recovery through lived experience of opioids specifically. I feel that I have good input and insight that I can contribute to the group. Upon getting sober, I managed sober living for multiple years. After that, I became the program manager here at No to Abuse, or Nevada Outreach Training Organization. So I deal very heavily and regularly with the homeless population and those in active addiction as well. And usually those two things together. And I'm definitely excited to see what we can do. I totally agree with what Elyse just said, that this is, in my eyes, a very huge opportunity, because I do deal heavily with grants, spending to utilize funds in a way that doesn't put us in a tiny box. So I'm super excited to contribute to where those funds are going to be allocated and how they can best serve our communities. So thank you.
Thank you, Jessica. Next, I have Karissa Loper.
Sure. Good almost afternoon, everyone. I'm Karissa Loper. I am also honored to have been appointed to the committee. So I bring the public health knowledge. Professionally, I have a master's in public health, grew up in the Division of Public and Behavioral Health, managing child, family, and community wellness programs, including immunizations, women, infant, children program, maternal child health, Title V, and chronic disease prevention. Very recently, I've moved over to the Division of Welfare and Supportive Services, and am now overseeing childcare. And am seeing, just from the social determinant of health level, I also teach public health policy at UNR for the undergraduates. So I'm constantly talking about social determinants of health, how that impacts people's health status and how it impacts their ability to seek out help and care and live thriving lives. So that's my professional aspect that I bring to this, and why I'm very interested in gathering all that information and then really using it to implement those recommendations that are going to come to us to make a difference in people's lives, to address social determinants of health, to ensure that they can get treatment when they need it. I just did an opioid module for my students, and I talk a lot about stigma. So I just want to point that out too. I'm very much on board with the chair, right? Destigmatization is very, very important in getting folks to feel comfortable coming to us for help, so that they don't continue through a vicious cycle. Personally, I also have some lived experience myself and with some family members as an adolescent, and I do bring that to the table as well, in knowing that it's hard to seek out help, and when you get involved with law enforcement and things and how that can impact your future, it's very scary to people. So that's me.
Thanks, Karissa. The next person I have is Lilnetra Grady.
Hello, everyone. My name is Lilnetra Grady, and I am also excited to be a part of this committee, hoping I can bring my expertise to the table so we can help move the state forward. But I am a nurse practitioner. I am also the chief medical officer for 3 FQHCs in the Valley. We are also a CCBHC, where we provide more comprehensive wraparound services. On the FQHC side, we provide mental health and primary care services. And I'm also a medication-assisted treatment provider. So thank you.
Thank you, Lilnetra. Sorry, I've been saying your name wrong the whole time. I totally did that. Oh, face and
no
response.
Problem.
But now I got it. Now I got it. If I say it 3 times, I can remember it and get it down. So
got it. Thank you.
Repeating it. Yes, yes, ma'am. After Lilnetra, we have Pauline Sala.
Hi, everyone. I'm Pauline Sala. I'm currently the Director of Juvenile Services in Humboldt County, Nevada. I think I've been here almost 7 years. Prior to that, I was the statewide juvenile justice specialist. So hopefully I can bring the adolescent and the juvenile justice focus in on this committee. I'm so excited to learn from all of you also. This has been, our last meetings have just been so informative, and I'm learning a lot. So I'll bring the juvenile justice piece, and also not to forget about our rural areas too. Thank you.
Thank you, Pauline. I think that is everybody that is a committee member that is in this meeting right now. Again, Sheila and her team will be working on putting out some bios, and we have our next meeting scheduled. So at this time, let me just check chat. We're good. At this time, I would like to move to agenda item number 11. Did anybody else want to share, Sheila? I didn't want to make you feel like I'm leaving you out, or I think that's, we know Henna. And yeah, I think Sheila, did you want to share? Or are we good?
Mr. Chair, I think that, the focus should be on the exceptional committee members we have, but thank you for the opportunity.
Yes, ma'am. I just didn't want to leave anybody hanging. So yeah, let's move to agenda item number 11, which is the adjournment of this meeting. This meeting is now finished, and we will see you at the next ACRN meeting, which is April 20th, 2022 at 9 a.m. Again, the minutes from this meeting will be posted on our DHHS webpage. And thank you for attending, and thank you for being a part of this committee.
Thank you, everyone.
Thanks all. Bye.
Thank you. Take care.
Bye, everybody. Thank you.
Bye.
Have a great day.
Thank you.